Zero.
Good morning, all. Knowledge conquers cancer. The new tagline embraced by American Society of Clinical Oncology, an inspiring and powerful statement, connects the cancer care with cancer cure. We are fortunate that we are witnessing a huge advancement in the field of clinical oncology with an effort to brush up the knowledge and the cancer care regarding gynecological cancer. The Bengal Obstetrics and Gynaecological Society, in association with the Breast Committee of FOGSI and the Oncology Committee of FOGSI, has brought eminent faculties, eminent speakers all together for today's 3-hour virtual webinar, which includes our 53rd Dr. Subodh Mitra Oration, which will be delivered by none other than Dr. R. Shankaranarayanan. Before starting the program, I would like to mention a few house rules. First, please keep yourself mute throughout the program. If you wish to speak, please post it in the chat box. We will do the needful. Second, please post your queries in the question and answer box. Your questions will be addressed by our eminent faculties at the end of each session. Any suggestions or comments are welcome. Please post it in the chat box. And 4, you are allowed to roam around within the wall of your house, but please switch off your videos so that we can't see.
Dipandita, now you listen. Sorry to interrupt.
Yes, sir. Yes, sir. Yes, sir.
It is audible now. Am I audible?
Yes, it is audible. Okay. Thank you, sir, for joining. Enjoy the day and keep listening to our program. So to start the program, I would like to call Dr. Sita Ramamurthy Pal. Can we have her CV slide, please? Dr. Sita Ramamurthy Pal, who is the Joint Clinical Secretary of the Bengal Obstetrics and Gynaecological Society for this year 2021, and who is also an East Zone Coordinator of Imaging Science Committee of FOGSI. So, Dr. Sita, please give your opening remarks.
Thank you, Dipanita, and a very warm welcome to everyone present here to this special CME on oncology. As Dipanita mentioned, this is organized by the Bengal Obstetrics and Gynaecological Society in association with the Gynaecology Oncology and the Study on Female Breast Committee, FOGSI. Firstly, I would like to wish all the beautiful and lovely mothers a very happy Mother's Day today and every day. Secondly, I would like to welcome all the eminent faculties and dignitaries present here, especially our teachers, Professor Biman Chakravarti, Dr. Kalidas Bakshi, Dr. Geeta Ganguly Mukherjee, Dr. Krishnendu Gupta, and our national faculties, a very dear friend, Dr. Nandita Palshetkar, our orator for the day, an authority on cervical cancer, Dr. Shankar Narayan, Dr. Bhagyalakshmi Nayak, who's the chair of the Oncology Committee, and Dr. Sneha Buyar, chairman of the Study on Female Breast Committee. Welcome you all once again to this virtual platform. As always, we have one ICOG credit point granted by ICOG, thanks to the chair, Dr. Mandakini Meg, and the secretary, Dr. Parag Biniwale. Today in India, we are going through a very difficult and trying times, and I would like, on behalf of the Bengal Obstetric Society, pay homage and respect to all the departed souls of our friends, relatives, colleagues, and all the martyrs who have given up or who have fought in this ever-going pandemic. And to conclude, I would like to quote Rabindranath Tagore, the Nobel laureate, whose birth anniversary we celebrate today, by saying his prayers on being fearless. It says, "Bipode more rakkha koro, enohe mor prarthana, dukkhe tape ব্যথিত চিত্তে, naiba dile shantana, dukkhe jano korite pari joy," which means, it is not my prayer that you save me from all perils. I pray that I should not fear when faced with odds. Console me not when I'm torn with misery. Rather grant me instead the will to win against grief. So praying for all our safety, to all our people, stay safe, stay healthy. Thank you, and thank you, Deepanita. Please carry on with the program. Thank you.
Thank you, Dr. Sita. Now let us start our scientific program. According to Globocan 2020, breast cancer is the most common cancer among Indian female, followed by cervical cancer. So to brush up our knowledge, our first session will be on breast cancer and on endometrial cancer. To further proceed with the session, I would like to call the chairpersons, Dr. Kalidas Bokshi. Dr. Jana, can we have, Dr. Kalidas Bokshi, who is a consultant obstetrician and gynecologist and oncosurgeon and ex-president of the Bengal Obstetric and Gynaecological Society, and Dr. Ranajit Mondol, who is the head of the Department of Gynaecological Oncology and also officer in charge in preventive oncology at Chittaranjan National Institute. To proceed with the program, please. Dr. Kalidas?
Hello.
Yes,
Good
sir.
morning, everybody. It is our great pleasure. It is my great pleasure and privilege to participate in this very informative and important session of gynaecology. Thereby, without wasting time, I am inviting Dr. Sneha Bayur, who will be speaking on the role of gynecologists in early detecting the breast cancer. Dr. Bayur, she is a governing council member of ICOG and FOGSI W award winner and recipient of American Award of Public Awareness Program. With these few words, I invite Dr. Sneha Bayur to deliver his presentation. Dr. Bayur, please.
I just wanted to add that not only Dr. Sneha is a dear friend, but she's taken the study of female breast committee of FOGSI to great heights, doing excellent programs and reaching out to a lot of women about breast cancer, about lactation and other breast problems. So congratulations, Sneha.
Congratulations.
Yeah, thank you so much, Dr. Bhaskar. But there is a power failure here, so I'm joining from mobile. So if you allow me, I think to take up my talk a little later, that will be better. Hello.
Yeah, okay, ma'am.
Yes,
No
sir.
problem.
Yeah,
Yes,
I have mailed you the presentation, Sita. If you can share afterwards, I think.
Okay, I'll do that.
Just do Sneha as the second speaker.
Yeah.
Yeah,
Yes,
thank you so much.
Dr.
Thank you.
Tulika, are you ready with your slides?
Tulika, you there?
Tulika will be the second speaker.
So I would request Dr. Mondol to introduce Dr. Tulika.
Yes, good morning, everybody. Our next speaker is Dr. Tulika Jha, who will be talking about the updates in endometrial cancer. Dr. Tulika Jha is the Associate Professor of Obstetrics and Gynecology at ICOG Medical College, Kolkata. She is a member, core committee, high-level task force for the maternal health, Government of West Bengal. It's a very important position. She is a state trainer for many training courses. She's the clinical secretary of BOGS, and she's the joint secretary of AICOG 2023. She has several publications in national and international journals. She has a special interest in vaginal surgery, high-risk pregnancy, family planning and contraception. May I ask Dr. Tulika Jha to start the program?
Thank you, Dr. Mondal, for the kind introduction. At the very beginning, I would like to share my screen. And is it visible?
Yeah, yeah.
Yeah, absolutely.
Okay.
It is visible.
Just before I start, Dr. Sneha, was her internet doing some problem?
They have lost the power there, sudden power failure. So she has mailed me the presentation. I've got it. You start. Okay.
Okay. Good morning, everybody. Good morning. And as Sita said, all of us are going through a very trying time. Hope things will improve. And as we have seen, there has been a plateau in the number of cases in some states. So here's praying to better times. Now, updates in endometrial cancer. As we all seen, the incidence of endometrial cancer is rising. When we were younger, we had very few cases. We used to see very few endometrial cancer cases, some few and far between. But for the last few years, I think everybody in your clinical practice must have got many cases, especially the classical endometrial cancer and also cases of other histological types which were not so common, but nowadays we are getting all of them. So if we start with the epidemiology in the United States, it's the most common cancer of the female reproductive organs, and the numbers there are also increasing, as are the numbers of endometrial cancer increasing in the UK. It has increased by almost 3/5 in the early 90s and around a 1/7 in the last decade in the United Kingdom. In India also, though cervical cancer still remains the leading gynecological cancer, increase in the incidence of endometrial cancer can be seen. And the rise in endometrial cancer in India is mainly attributable to changing trends in the lifestyle and reproductive profile of women, especially in urban areas. Now, what happens is this changing trends in the lifestyle they have exposed us to many risk factors which are directly linked to the incidence of endometrial cancer. These are the risk factors which we all know about, but as we can see, the factors itself are increasing in the society and in Indian women in general. The prolonged estrogen exposure, early menarche, late menopause, nulliparity, and ovulation, especially due to PCOS, has become a real problem. The demographic characteristics of Indian women have changed over the years. Increasing age, 55 years, women are living more. Moreover, hysterectomy due to benign causes have decreased in number, and so this makes them more susceptible to malignancy in the later years of their life. The socioeconomic status improvement has led to increase in high risk factors, and of course there has been an increase in the family history of uterine malignancy, which are hereditary. Associated medical illnesses have increased, like diabetes, obesity, hypertension. Another important point is previous pelvic radiotherapy also increases, and the relative risk increases by 8 times in women who have already undergone radiotherapy due to some illness, some malignancy. And tamoxifen is also, because breast cancer survivors take tamoxifen for years, usually 5 years or more, and so they also become susceptible to endometrial cancer. Now, types of endometrial cancer, we all know. Before going into the updates, I would just like to just talk a bit about the basic. That is, we know type 1, type 2, familial or hereditary type. The basic difference between type 1 and type 2 was type 1 was mainly endometrioid and diagnosed at an early age, usually in premenopausal women, and it is usually caused by excess estrogen in the body. And the type of the subtype of malignancy in these women were grade 1 and 2 endometrioid, which had a good 5-year survival, usually more than 95%. On the other hand, the type 2 was not so has a bleak outcome. It is diagnosed at a much later age. Estrogen is not involved. Usually it happens in atrophic endometrium. These are usually aggressive with a high grade. Stage at diagnosis is also late. The non-endometrioid tumors are mainly involved here, and the mutations in the two types are also different, as you can see. The number of cases which are due to the non-endometrioid cancers are fewer in number, but then proportionately the number of deaths due to endometrial cancer in the non-endometrioid cancers are more, they're more common to lead to death in such women. Now, we know about Lynch syndrome and the HNPCC, which is the hereditary non-polyposis colonic cancer and endometrial CA. This has a link. This is an autosomal dominant inherited disorder. 2 to 5% are attributable of cases are attributable to Lynch syndrome. Basically, there are germline mutations in DNA mismatch repair genes, which increases their lifetime risk of developing endometrial and colorectal cancer by 40 to 60%. This is becoming important because genetics and mutations, testing of mutations, DNA ploidy are coming in a big way in the management of endometrial carcinoma. May not be in our country, but sooner or later it will be here. But in the Western world, these lines of treatment, these lines of investigation are being followed much rigorously. And these women also require surveillance much closely from the age of 35 years annually, and prophylactic surgery, that is hysterectomy, may also be contemplated in these women as soon as they reach the age of 40. Molecular typing has become important. Next generation sequencing has shown 4 molecular subtypes, and especially in the PROMISE study, it showed a new reproducible way of classification of endometrial cancer, but it was seen not to be very cost effective. But a new surrogate typing based on immunohistochemistry has come, and that is divided into 4 types, as we can see: the pole mutations, MSI, copy number low or copy number high, and these are also, this also help us in classifying endometrial cancer and also improving the prognosis. Now, diagnosis, we all know the main problem is AUB, and postmenopausal bleeding is also a very important complaint of these patients. And the probability of endometrial CA in women with PMB is 5 to 10%, which increases with age. But we also have to remember an increasing cohort of serous or clear cell tumors, which behave like aggressive ovarian cancers, and these patients may present with pelvic pain, ascites, and the complaints of advanced ovarian cancer. But the history is important as usual, but in endometrial CA, the history of comorbidities and the use of hormones or tamoxifen has to be elicited, and family history of malignancy, especially uterine, colorectal, genitourinary, has to be elicited. Now, the women with PMB should receive an examination, proper examination, abdominal, spectrum, pelvic, everything, and also endometrial sampling may be required in these women. Now, investigations, we all know USG, TVS, MRI, CT scans. So what should be our way? What should we do one after the other? So first line imaging modality is still TVS. It is helpful in triaging symptomatic patients. It also helps us in assessing uterine size, the endometrial thickness, endomyometrial interface, myometrial ecotexture, adnexa. Obviously, the thickness of 4 millimeters or more in postmenopausal women is an important cutoff, but also the look of the endometrium is important. And other than the thickness and all, we also have to see whether there is any polyp collection and all. Normal endometrial profile, and if it is less than 4 millimeters, the important thing is, and unless there is recurrent postmenopausal bleeding, the negative predictive value is almost 99%. So if the patient does not have any further bleeding and the thickness is less than 4, we can jolly well say that this patient does not have cancer, but obviously we'll have to keep her under watch, but the negative predictive value is quite high. Now, endometrial sampling. Yes, endometrial sampling has to be done. Office people is preferred for the initial evaluation. And if it fails, then DNC may be required. Important is tumor type and grade of the lesion must be mentioned in the pathology report. Fractional curettage, there is some question, especially in these patients where we are suspecting a extension to the cervix. FIGO says no, it is not of much use, but the ICMR consensus update says yes, if there is a suspicion, then we have to go for endocervical curettage before aspiration, and also we may need to go for colposcopy and endocervical evaluation if we see abnormal glandular cells. Hysteroscopy is not always required. It can be carried out as office hysteroscopy in an outpatient department, especially in women where ultrasound irregularities can be seen and high risk of endometrial cancer is there. Recurrent postmenopausal bleeding should also be investigated by hysteroscopy. It is the gold standard where we are suspecting focal endometrial cancer. It is sensitive in local lesions, but not very helpful in diagnosing early disease. And a single stop approach can be done, which is office hysteroscopy, directed biopsy in a focal lesion, and vacuum sampling of endometrium in a normal looking endometrium. Three important points have to be seen, that is histological type of the lesion, the stage of the lesion, and the grade of the lesion. Now, prognostic factors, we all know the common things, but also important are the tumor size, the positive peritoneal cytology, hormone receptor status, DNA ploidy, type of primary therapy, if there was any, then moreover peritoneal wash, the nuclear grade and hormonal status has also to be done. Now, pathological types, we know there are two main groups. One is the endometrioid and the non-endometrioid. The non-endometrioid are the more dangerous malignancies, and they are increasing in number. So we have to be aware about them as well. And there's another thing, which is the histopathological grade. So basically, we got type 1, type 2 malignancies, group of malignancies. There is the histological type of the malignancy, and also the histopathological grade. It can be grade 1, 2, 3, depending upon the percentage of non-squamous or non-morular solid growth. And also nuclear atypia is an important point for grading a lesion. Well, where FIGO has graded it into 3, well differentiated is grade 1, moderately differentiated is grade 2, and poorly differentiated is grade 3. These grades are very important in the management of endometrial CA. So though sound boring, but we have to have an idea about them. So it basically depends upon the growth pattern of the mass and also the atypia within the cell proper. Now, pre-operative workup is also important. In the mandatory workup, family history, general assessment, geriatric assessment, clinical examination has to be done. Pathology assessment has to be very particular about the patient, especially the histotype and the grade. The normal routine tests we have to go about. In the special tests, CA125 and HE4 may have to be done in some cases, though it is not routinely recommended, especially in cases where there is extensive metastasis outside the uterus. So in those cases, these markers may be increased. Now, MRI is the most accurate modality for assessing the size and extent of tumor, myometrial invasion, extension to cervix, adnexa, and lymph node involvement. This is very important. The endometrial staging of endometrial cancer is surgical staging, surgical-pathological staging, but we need to have an idea, a clinical staging in our minds when we go for surgery, because whether our steps of surgery will be dependent upon what we have assessed the patient preoperatively and how we have assessed. So for that, MRI becomes important. CT scan can also be done, but it is not so helpful as MRI, but it is mainly utilized for assessing extrapelvic disease and lymph node involvement. PET CT scan is definitely very sensitive and specific, but it is mostly for assessing distant metastasis and high-risk cases or with recurrent disease. It is not very beneficial in assessing primary tumor extension or preoperative staging purpose. I won't go through the staging. Everybody knows the staging of FIGO, the latest staging of the FIGO for endometrial cancer. Just a few important things. FIGO is telling, though it does not alter stage, positive cytology, peritoneal washing needs to be done, and positive cytology has to be recorded while doing laparotomy. So, and we have to keep that in mind. Now let's come to the management. Important factors for the management: grade of the disease, stage of the disease, histological type, what surgery we are planning, lymph node sampling versus lymphadenectomy, and adjuvant therapy. Main modality, surgery is still the mainstay, but we have adjuvant therapy in the form of radiation, chemotherapy, hormonal therapy, targeted chemotherapy, etc. Stage 1. Stage 1, though, has the best prognosis, but it is the most confusing in the way, because in the regard that whether to go for lymphadenectomy or not, if yes, how many lymph nodes, how extensive should be the lymph node dissection. So this is one important stage which we have to undergo carefully. Now, staging laparotomy, basically extrafascial type 1 or simple hysterectomy with bilateral salpingo-oophorectomy should be done. Vertical incision may be needed. Peritoneal washings is important, and a gentle, careful palpation of the entire peritoneal cavity needs to be done. Though peritoneal cytology does not change, as I said, it is recommended to have a peritoneal washing and sent for cytology. Usually pelvic lymphadenectomy is done if required, but if tumor we know is of endometrioid histology, complete surgical staging, including para-aortic lymph node dissection, has to be done, and omental biopsy or omentectomy may be also may need to be done in these patients. So in stage 1, where should we do lymphadenectomy? There is a risk stratification in which we divide the patients into three categories: low, intermediate, high. In the low risk, not recommended. In the intermediate group, can be considered, and in the high risk, it should be done. There are different risk stratification systems as well. In the Mayo Clinic, stratified the risk this way: low, intermediate, high, where the grade was important, biometrial invasion, size of the tumor was important, and in the high risk, the non-endometrioid group of the cancers were also important. But the incidence, and if we follow this risk grading system, the incidence of missing nodal disease was only 0.8%. The Korean group also had a categorization in which they also added extrauterine disease, the point of extrauterine disease, the absence of enlarged lymph nodes, the CA125 levels. And if we followed Korean GOG group risk stratification, the chances of missing nodal disease was 1.7%. So lymphadenectomy has to be done in the high risk category and may be done in the intermediate risk category. So how much what is the extent of lymphadenectomy? It has been a matter of considerable debate and extensively investigated in several studies. The problem is the patients of endometrial cancers have many comorbidities and they are poor surgical risk. They are of poor surgical risk. So the unnecessary lymphadenectomy may, there may be increased post-operative morbidity in these cases. So we have to judicially decide how much, what should we do about the lymph nodes. The baseline rate is 9% in endometrial cancer, and the surgical complication rate is also 6 to 20%, which is slightly more than the nodal disease. So we have to be very careful in which cases we go for lymphadenectomy and in which cases we not. If we go for lymphadenectomy, we have to decide how much should we go. Usually para-aortic lymph nodes, pelvic lymph nodes are removed, and para-aortic lymph nodes should be removed in positive pelvic nodes, palpably enlarged para-aortic nodes, if the cervix and adnexa are involved, if the tumors are of a high grade, and non-endometrioid histotypes. There was a trial in 2010, the CEPAL trial, which concluded that if lymphadenectomy has to be done, it should be both pelvic and para-aortic, and both the lymphadenectomies should be considered. Sentinel lymph node biopsy is coming in a big way in endometrial cancer. It was common in breast cancer management, but it has also become, it is still experimental in endometrial cancer, but it will gain more importance as we will see in the coming years. It is a compromise between no pelvic lymph node dissection, and which may, because of which we may leave a small proportion of node positive women, or no dissection at all, or maybe huge dissection, which is basically a useless procedure for the majority of negative patients. So this is sort of a midway or a pathway between the two, a thin line between the two categories. As we know, it is done by injecting dyes into the cervix, which could be technetium sulfate or indocyanine or lymphosyncytiography could be done. And basically the sensitivity is pretty high. If the sentinel lymph node is positive, then we should go for pelvic lymph node dissection. This was the standard of care in breast CA, but routine use is not yet common in endometrial cancer. The ICG, the infrared technique with ICG has been found to be very sensitive and specific in detecting sentinel nodes. There was also a study in which ICG dye during robotic surgery showed very high sensitivity and negative predictive value. In stage 2, radical hysterectomy, in stage 2, the cervix becomes involved, but radical hysterectomy is not recommended routinely. Modified radical hysterectomy may be done if we require for obtaining free margins. Lymphadenectomy is usually recommended for this stage. In stage 3 and 4, Usually the the tumor is outside the uterus, and so complete macroscopic cytoreduction and comprehensive staging is recommended in these stages, and multimodality management should be considered for the treatment of advanced endometrial cancer when surgery may significantly the vaginal function. So, is minimal invasive surgery or robotic surgery or any other surgery considered in a management of endometrial CA? Yes, these can be considered in the management of high-risk endometrial cancer as well, but not in advanced stages. In people who are, in women who are not fit for or who are high risk for surgery, especially medically, they can undergo vaginal hysterectomy with salpingo oophorectomy. Several studies have been done regarding to prove the feasibility, safety, and efficacy of minimal invasive approach. But the important thing is morcellation or tumor fragmentation has to be done in bag. It can not be done in in the open in the peritoneal cavity. There was a LACE trial which was conducted in 2017. This also showed that there was no statistically significant differences in recurrence of endometrial cancer in groups of women who had undergone abdominal hysterectomy, open abdominal hysterectomy, and TLH. So they were followed up. 760 women were followed up for quite some time, and the two arms were comparable as far as recurrence was concerned. And in survival was also comparable in the two arms, and the intraoperative complications was also not too different in the two groups. Obviously, shorter hospital stay was shorter, and post-operative adverse events were shorter, fewer in the TLH group, but the operating time was a bit longer. So we have to, we can go for minimal invasive surgery, but the important thing is the surgical skill and the expertise of the surgeon becomes important in such case when dealing with such cases. Now, adjuvant therapy, to give or not to give. First question was whether to resect lymph nodes or not. Next question is whether to give or not to give adjuvant therapy. Risk, again, there are different risk groups which the ESMO, SGO, and ESTRO have formed by risk stratification. And this guides us whether to give adjuvant therapy or not. There are 6 groups: low, intermediate, high intermediate, and the other 3 are high, advanced, metastatic. As we can see, low, intermediate, high intermediate is basically stage 1, the different kinds of stage 1. And stage 1B, grade 3 is in the high group. Stage 2, advanced, stage 3, stage 4 are all in the bottom half of the table. So basically the confusion is whether to go for adjuvant therapy in stage 1, different types of stage 1 cancer or not. Basically in stage 2, 3, 4, you have to go for adjuvant therapy in in all the cases. But the question arises when we are dealing with stage 1 cases. So this table helps us in taking a decision whether we need adjuvant therapy or not. In patients with stage 1 with low intermediate or high intermediate, adjuvant therapy as such has no impact on survival, but it reduces the rate of pelvic recurrence. Adjuvant chemotherapy and adding adjuvant chemotherapy to radiotherapy also does improves progression-free survival, but an overall survival benefit is unproven. So basically, overall survival does not increase with RT or CTRT, but a progression-free survival can be better in such cases on giving adjuvant therapy. So it's pretty detailed. So I would just say in the low risk category, adjuvant therapy is usually not required. In intermediate category, if the patient is less than 60, we can go for observation or opt for adjuvant brachytherapy. In the high intermediate, depending upon whether the nodes were negative, if the nodes were negative, no adjuvant therapy or brachytherapy. And if the staging was not done, as happens many a times in stage 1 carcinoma, we do not go for nodal resection. And if the nodal staging was not done, then we err on the side of caution and we go for EBRT or adjuvant brachytherapy, depending upon the lymph vascular space invasion report and the grade of the tumor. In high risk stage 1, these were the low, intermediate, and high intermediate. In high risk stage 1, if the node is negative, adjuvant EBRT with limited fields can be considered. And if the staging was not done, then brachytherapy may be considered, or adjuvant EBRT, that is extensive pelvic radiotherapy, has to be given. In high risk stage 2 patients, if simple hysterectomy was done and nodes were negative, recommend vaginal brachytherapy to improve local control. And if staging was not done, if the surgical node staging was not done, then EBRT is usually recommended. So basically, if the nodes are negative, we know the nodes are negative, so we can go for brachytherapy in many cases. But if we don't know the status of the nodes, then we have to go for extensive field therapy, pelvic radiotherapy. And we can also consider brachytherapy post then. In high risk stage 3, EBRT is recommended. Chemotherapy is also recommended. They can be given in combination depending upon the stage, with 3A, B, C1 or C2. And in advanced and recurrent disease, surgery has to be done, which is usually exenteration or optimal cytoreduction, or palliative surgery can also be considered. Histological type should not influence the decision here, because as it is, the disease is advanced and recurrent. Radiotherapy is important. If primary therapy consisted of surgery alone, radiotherapy represents an effective salvage strategy in these patients. It is with curative intent. For vaginal or pelvic nodal recurrence, chemotherapy can be given as well. In such patients, re-irradiation may be necessary in some patients. Sometimes palliative radiotherapy is given for local recurrence or systemic disease which are causing symptoms. Chemotherapy is also considered, especially in the advanced cases, in stage 4 cases. The neoadjuvant chemotherapy is also coming in a big way in patients, especially in the non-endometrioid, which be present late in a advanced stage, and then we can consider neoadjuvant chemotherapy in such cases, usually with carboplatin paclitaxel. Doxorubicin is also a drug which is considered for chemotherapy. There have been various trials. We know POTEC, GOG99, POTEC 1, POTEC 2, POTEC 3 trials, which basically considered, in POTEC 1, basically the comparison was between observation and EBRT in women with stage 1B, 1C. It was seen that loco-regional recurrence were high in the observation cohort, but the overall survival benefit was not too different in the two groups. But the local spread was less. Then we move on to the POTEC 2 trial, in which vaginal brachytherapy was compared with the EBRT, and it was seen that the aim was to establish optimum effective modality, but it was seen that there was no significant difference in the overall survival and disease-free survival, but the quality of life and toxicity profile were better in the vaginal brachytherapy arm. In the POTEC 3 trial, the investigation was done for the role of adjuvant chemotherapy in concurrent or sequential, either concurrently or sequentially in women with endometrial CA. And there was no difference in overall survival, but the 5-year failure-free survival was better in the chemoradiation arm, which was the combined arm. So these trials, this was as recent as 2016. So there have been other studies also comparing chemotherapy with pelvic radiotherapy, but most of the studies, the overall survival rate is not different in the two arms, but the local disease-free progression, disease-free survival is better in the arms which have gotten adjuvant therapy. There was also the GOG 122 trial, in which was conducted in stage 3 and 4 diseases. There are several ongoing trials as well, where pemetrexed disodium, paclitaxel carboplatin with metformin hydrochloride are being investigated. Monoclonal antibodies are being investigated. So in coming days, I think we will have a few more things in our armory to deal with advanced malignancy and advanced endometrial CA. Surgery for non-endometrioid types are a bit more extensive. Surgical resection has to be done. Comprehensive surgical staging is mandatory. Lymphadenectomy is mandatory. And usually staging omentectomy also has to be done in serous carcinoma, mandatory in clear cell, undifferentiated, and carcinosarcoma. In the high risk categories, what about adjuvant therapy? You consider, usually chemotherapy is considered, and along with chemotherapy, EBRT may be given. Brachytherapy in the first stages.
Dr. Tulika, please, sorry to interrupt you. You have 2 minutes left.
Okay, thank you, Dipanita. Stage 1, we have brachytherapy. 1A, we can consider brachytherapy, and 1B, we can consider EBRT along with chemotherapy. The role of hormonal therapy is also there. It is indicated in advanced or recurrent endometrioid endometrial carcinoma. In such cases, the hormone receptor status is important to know. Progestogens like medroxyprogesterone acetate or megestrol acetate can be used. Tamoxifen aromatase inhibitors are also used as hormones in advanced or recurrent endometrial CA. This is a comparison of the studies which showing the impact of hormonal therapy, but it shows the response is not really good. And whatever be the drug, whether it's MA or MP or anastrozole or letrozole, the progression-free survival or the overall survival and the response are not very optimistic. Fertility preserving therapy can be done in patients. Sometimes it becomes necessary when patients are young and their family has not been completed. So we have to think about that. But before that, DNC with or without hysteroscopy must be done. Diagnosis must be confirmed. Patients should be counseled about the pros and cons of fertility preserving. In these patients, progesterone therapy can be given, or LNG IUS or GnRH analogs, and reassessment should be done every 6 months. And if there is no response, then after 6 months, we need to go for standard surgical treatment. And if there is a response, then the patient should be considered, should be asked to delay pregnancy and should go for pregnancy once she has been given the clean chit by the doctor. Ovarian preservation is an important part. I won't go into the details because Nandita will be talking about it today. The survival rates, as we can see, are good in the early stages, but poor in the stages, as with all cancers. And screening, yes, routine screening has not yet come. In asymptomatic patient, we don't need to go for routine screening for endometrial CA, but in asymptomatic women, is also not in the high risk groups. Also, it is not increased. It's not routinely recommended. But if patients have adult granular cell tumor or tamoxifen users, or if they have one of the hereditary syndromes, we may have to go for routine screening. And to conclude, endometrial cancers are rising in numbers. We know, especially the non-endometrioid variety. Unopposed estrogen is still the major risk factor. Surgery is also still the mainstay, but lymphadenectomy and adjuvant therapy have come into the picture, and especially adjuvant therapy. And this helps in disease-free survival of the patient. Progestin therapy is also important. So thank you for your patient hearing. Thank you, Dipannita.
Thank you. Thank you, Dr. As an extensive review of the recent trends in management of endometrial cancer. I think she has really completed majority, has touched major points. Many of you may ask whether should we go for extensively doing the lymphadenectomy during the procedure of TH-BSO, or and the thing is whether should we go for adjuvant therapy. Those things are very important, and Dr. Tulika has clearly cited all those conditions where postoperative adjuvant therapy is required or not, and when you are going to go for lymphadenectomy. Of course, lymphadenectomy is not at all required in majority of the endometrial cancers. So you can carry on doing the TH-BSO, but you have to always think about the risk factors. Those risk factors are very important. Based on the risk factors, you have to carry on the lymphadenectomy, not doing everybody, because lymphadenectomy itself has got its own problem. So may I ask the people to ask questions and comments?
No, after all, Ranjit, it will be after the first lecture.
Okay.
After the session, yes.
After the session.
Okay.
May I ask our first speaker whether she'll be able to deliver her lecture or not at present?
Yes,
Yeah.
thank you so much, sir. And sorry for the technical hassles which happened exactly at the same time. Very good morning to one and all. At the outset, I would like to thank dear friend Dr. Bhaskar Pal, President BOGS, who is also the advisor for breast committee, Dr. Ram Prasad, Secretary BOGS, Dr. Sir Krishnendu Gupta, Dr. Basav, Dr. Sita, Dipanvita, Dr. Tulika, and the entire team BOGS for giving me this opportunity. And yes, I'm happy that the discussion has started. What is the role of gynecologists in early detection of breast cancer? Whether this is the domain which really belongs to us. And I'm happy that I'm invited as chairperson to share my views. So without much ado, I will just start with my presentation. And I will just start by introducing this topic, what is breast cancer? This is nothing but malignancy of the breast tissue, which starts in any part of the breast. May it be lobule, may it be the ducts or stroma, and it spreads to other parts of the breast. The axilla may be the opposite breast, and it can spread the entire body and can lead to many complications and death of the women. If you look at the incidence is very high. Why do we have to discuss so much about this breast cancer? Because this is one of the two leading causes of deaths of women of India, not only India, but across the globe. And every woman has almost 1 in 8 chance of having the breast cancer during her lifetime. And that's a very reason we are so much worried that how we can control the incidence of this breast cancer. So if you look at the statistics of 2018, there are 1,62,468 new cases for that particular year. And the incidence is 14% if we think about combined for both sexes. But if we just analyze it as male and female, the incidence for women, it is almost 28%. And that's a very reason we have to take care of this cancer, which is so high in incidence. At the same time, it's getting presented at a very late stage, which of course interfere with the management of the disease, and the survival is hampered. So as far as the age is concerned, if you look at this graph, by the age of 35 to 39, it is almost negligible, but it steadily starts rising and it reaches its peak by 70 to 75 years. If you see the incidence by age, at the age of 20, it is 1 in 1600, but by the age of 40, it is 1 in 69. So that is the importance of the age. So what is our role in this? Breast cancer is one of the two leading causes of deaths in women, as I have already said, not only in India, but across the globe. Previously, cervical cancer was the #1 killer for women. But over last 2 decades, this picture has changed. The reason from both the sides, the falling incidence of cervical cancer because of knowing the exact etiology, of course, the preventive measures like vaccination and the lots of general public awareness and the screening strategies which are so well organized. On the other hand, you have the incidence of breast cancer, which is rising very high. The reasons being the etiology exact, not known, there is no vaccination, there's lack of awareness amongst the general people. At the same time, the socio-cultural taboos. The men don't want their wives to go to the doctor and get their breast examined. Women, they feel shy about their breast and exposing to the doctor, sharing their problems with the doctor. Breast cancer cases, that's the very reason they are diagnosed very late. If you compare the Western world and India, in Western world, the cases for breast cancer are very high, more in number, but almost 60 to 70% of the women, they are diagnosed during first stage, that is early breast cancer, which can be managed very effectively and complete cure is possible. But for India, the almost 3% of the cases only they present as early breast malignancy, and that's the very reason the spread of the disease, metastasis, the complications and associated mortality is very high. Of course, the cure is almost impossible. So across the world, it has been observed that, as you all will agree to me, I'm also a hardcore obstetrician like you all, most of you all. And celebrating the breastfeeding week every year and managing only the problems related to breastfeeding, these were the jobs done by us. But being surgeon's wife, I have seen advanced cases of malignancy, breast malignancy being operated, and so many women landing up into long-term therapies and complications. So the outcome is very poor. And that's how the thought came to our mind that if we gynecologists take up this duty to examine the breast of these women, definitely this is going to help uh, the women of India to, of course, detect their breast cancers very early, and we can save their lives. So by virtue of the gynecologist practice, we are tackling with breastfeeding, promotion breastfeeding, problems associated with breastfeeding like mastitis, engorgement, breast abscess, even lactation inhibition we are tackling. At the same time, certain endocrinological disorders like mastalgia, galactorrhea, even hormone replacement therapy and hormone therapy, which the oncophysician advises, we are monitoring them as in follow-ups. So we gynecologists are tackling the field of breast. So why not to take up this as priority? So to accomplish this, why we have this hesitancy? Because we have not received adequate training during our postgraduate curriculum. And to accomplish this, the American Board of Obstetricians and Gynecologists, they have provided guidelines to integrate this basic teaching for breast disease in the postgraduate curriculum. I feel this also should be applied to India as well, because the women prefer to go to their gynecologist for their breast problems rather than to surgeon. Until then, we are not exposed to such intensive training as postgraduates. We have to treat breast as gynecologist domain as far as breastfeeding and the problems associated with it. Benign breast diseases, early detection of breast cancer is also is concerned as well. We have the major role as preventive oncologists. So to do this, let us understand the basic anatomy and physiology of breast. This is the gross structure of the breast, where you have these milk secreting glands, that is the lobules, and these wide tubular structure, milk collecting ducts, and the intervening stroma. So malignancy can start in any part of the breast, may it be stroma, duct, lobules. This is the lymphatic system of clinical significance because the disease spreads through this. The main lymphatics or lymph nodes which are of major concern are low axillary, mid axillary, high axillary or apical, and supraclavicular. So we have to have this basic knowledge of anatomy, how this disease spreads, so that when we teach the patient or when we examine the patient, we should know what areas are to be examined exactly. Estrogen and progesterone, as you all know, these are the female hormone. They are produced they have no symptoms of this malignancy till it is very, very advanced. May it not be accessible to the treatment, the surgery, or even chemotherapy. And it may not be completely curable. And that's the very reason our message is always that breast is such an easily accessible organ. And if we teach them properly and adequately self breast examination, the women can be aware of their breast. They can examine their breast regularly, and they can notify any abnormality and report to the gynecologist or the clinician for that matter. So lump in the breast, the size of the breast, may it be enlarged or small size, eczema, nipple discharge, retraction of the nipple, all these women, all these problems, the women seek advice of gynecologists. In short, gynecologist is not only the obstetrician and gynecologist delivering babies, but their primary physician as well as primary surgeon. And so whenever the woman comes to you for any of her problem, make it a habit, make it a point to examine her breast see that whether she has any abnormality, notify it, and if at all she has any abnormality, subject to her for further investigations. If there is no abnormality, you take this, you utilize this opportunity, teach her self-breast examination, make her breast aware, and see that she has to examine her breast every monthly post-menstrually. How to do that in details, I'll be coming to it later. So definitely, we gynecologists always have a role of a counselor. We have to provide adequate and appropriate information about breast cancer. We have to make them aware of their breast, teach them self-breast examination to examine their own breast every monthly during the postmenstrual phase. And if any abnormality, she has to report to her clinician immediately. The clinician should do detailed clinical examination. Of course, it should start with family history. Family history is so significant in cases of breast cancer, though only 10 to 15% of the cases are familial or inherited. It is of significance because that categorizes you as high risk. And of course, your scrutinization will differ from the average risk woman. Personal history, medical history, all this have to be taken into consideration. The clinician has to perform in depth the clinical breast examination. Similarly, inspection, palpation to see whether there is any nipple discharge. So all these have to be done. And if at all she finds anything significant, she has to subject this patient for imaging investigation as well as tissue diagnosis. Of course, effective and timely referral for appropriate treatment if at all she is diagnosed of having any malignancy. Counseling for choice of treatment, of course, whenever suppose a young woman is diagnosed as a case of very early breast cancer, so definitely they will ask you whether it should be radical or conservative breast surgery, because the oncosurgeon will always offer her the options. So gynecologist is the one who can help these women, because over the period it has been proved that radical surgery, previously we had only one treatment and no other option. So radical mastectomy was with axillary block dissection. But nowadays it has been proved beyond doubt that if the malignancy is early, then definitely you have a choice for conservative surgery, which we label it as oncoplasty, which utilizes the principles of good oncological control, that is no local or distant, no local recurrence or distant metastasis. At the same time, it follows the principles of plastic surgery, that is to maintain the cosmesis. Of course, the adjuvant, neoadjuvant hormonal therapy, monitoring of the side effects, and subsequent follow, everything comes in our domain. So why should we screen? Of course, screening, as you all know, whenever you do a screening for asymptomatic general population, the outcome is always good. The disease is caught in asymptomatic or very early stage, and of course, the prognosis of that particular disease is very good. So looking at this various organizational screening recommendations, we have United States Preventive Society Task Force, American Cancer Society, American College of Obstetricians and Gynecologists, American College of Physicians, American Association of Family Physicians. All of them almost agree that the screening for an average risk woman should start by the age of 40 years. And of course, all of them agree that it should continue till 75 years. And then, of course, you can stop it when the life expectancy is less than 10 years. To summarize, for average risk woman for breast cancer, the self-breast examination should start from the age of 20 years, though it is optional, and it has to be every monthly postmenstrually. But clinical breast examination should be every 3 yearly, once in 3 years. Mammography for average risk women should start from 40 years. 40 to 44, you can offer them and it can be optional, but 45 to 54 years, it should be regular and mandatory. 55 to 70, once again, you have to taper down to every 2 yearly till the age of expectancy, life expectancy is less than 10 years. If you have a woman who is high risk, as we have categorized from her family history, or if she has history of BRCA mutation, then of course mammography and MRI annually has to be started. As we have seen, the screening strategies are not organized. We can say for breast cancer, the screening strategies are almost non-existing in India. And that's the reason we have to utilize this window of opportunity and go for opportunistic screening. So we categorize this screening into three parts. That is, one is cancer prevention. That means who is at risk, you notify that, identify those women and put them under surveillance. Breast screening, examination of breast, and genetic screening. So as I have already said, because like cervical cancer, nobody has been able to identify the etiology of breast cancer. It is still in doubt. And of course, familial association has been found in 12 to 15% of cases. And hereditary breast cancers are found in 5 to 10%, that is those who are associated with BRCA1 and BRCA2 mutation. That means almost 70 to 80% are the women who do not have any family history or BRCA mutation association. So definitely you have to identify these women from the common mouth, and that's the very reason you have to do universal screening for breast cancer. So what are the risk factors? There are certain risk factors which are modifiable and certain non-modifiable. So you are a woman, that itself is a risk factor for you. Your advancing age, as we have already seen, that from 40 years onwards, the risk rises exponentially. Family history, as we have already said, 10 to 15% of the women, they have family history and they are put as categorized as high risk. Early menarche and late menopause, that is a longer period of exposure for estrogen, increased breast density, chest irradiation during early life, BRCA1 and BRCA2 mutations. These are the non-modifiable risks. That means you cannot alter these risk factors, but definitely you have something to do for these modifiable risk factors: obesity, alcohol, age at first child, your breastfeeding practices. That means having a child after the age of 30 or having only a few children, that is maybe one or at the most. Or breastfeeding practices, you have not breastfeed your child exclusively for the first 6 months and maybe 2 years and onwards, you have not done the proper breastfeeding. Use of hormonal contraceptives and hormonal replacement therapy in the later life. So definitely these are the modifiable factors. Why fatty women have the higher chances? Because in addition to ovarian estrogen, you have the chance for, you have extra ovarian estrogen from the adipose tissue, and that's how you are exposed to it. Your risk for malignancy is high. Certain symptoms like new lumps in breast and armpit, thickening and swelling, irritation or dimpling, redness or flaky skin, nipple discharge, change in size and shape of the breast, and pain. These are all the symptoms which raises suspicion. And but in spite of this, even in the absence of these symptoms, the women are supposed to go for self-breast examination, and they should start it by the age of 20 years. How do they should do this? They have to expose their breast in front of the mirror, stand in with the arms by the side, raised above the head and on the waist. Initially, we have to do inspection, look for the shape and size and the symmetry of both the breasts, whether you have any lump or dimpling, whether you have discoloration of the skin, scaling of the skin, podarunge appearance, retraction of the nipple. All these things have to be observed. Then you have to do palpation with the hand, with your palmar aspect of the hand. Palpation has to be done from upside down, as you can see this upper figures, the side to side, upside down, concentric or radial. So the aim is not to miss any part of the breast. And at the end, of course, you have to see for any nipple discharge and what kind of nipple discharge, then you have to investigate. Similar examination, when the clinician does it without using any gazette, then we label this as clinical breast examination. As we have already discussed, that if the clinician suspects or the woman is high risk, then of course we have to subject her for mammography. But even for average risk women, this is the recommendation for mammography, which we have already discussed, which is guided by the American Cancer Society. Now, for younger women, ultrasonography is the investigation of choice. But definitely, whenever we have some doubt regarding the nature of the lump, whether it is solid or cystic, and whether it is deep-seated. So to confirm our diagnosis, and if at all we want to take biopsy from a deep-seated lump, ultrasonography is definitely helpful. Nowadays, sonomammography, the combined investigation, is the investigation of choice. MRI, of course, is not a routine investigation as far as the diagnosis or screening of breast cancer is concerned. It is done only when sonomammography, that is sonography and mammography, both are inconclusive, or in high risk women when you need to do it annually. So once you confirm this, once you have this suspicion, you need to confirm this by tissue diagnosis. The age-old method of fine needle aspiration cytology is no more recommended because it is not very conclusive and most of the time sample inadequate. That's what the reports come. True cut or core biopsy is the most recommended method, and that's you better get well versed with this very simple procedure. As we are doing such a major surgeries, it is such a simple and easy procedure. You can learn it once and get accustomed to it. The results of histopathology are comparable to that of excision biopsy, that is lumpectomy. Of course, you have one more choice, that is stereotactic biopsy, which is the mammographically guided biopsy. So once you diagnose that this woman has breast cancer, we do the risk assessment by clinical staging, pathological grading, and most important prognostic factors as tumor size, axillary lymph nodes, ER/PR status, and HER2 status. So this is just to make it short. Now, why do we need to do this? Because as gynecologists, our aim is to detect this malignancy as early cancer, early breast malignancy. So that is before stage 2A. That's the reason this attempt of showing what is stage 2A. You have stage 2, stage 0 as carcinoma in situ. 1 is the T1, that is tumor size less than 2 centimeter. 2A is tumor size 2 to 5, but no nodes. And 2B is tumor size 2 to 5 along with lymph nodes, axillary lymph nodes. So we want to catch this before 2A. Of course, the grade of the malignancy, histological grade, definitely has a impact on the prognosis, because the more poorly the differentiated malignancy, poor will be the prognosis. Now, once you remove the tissue, you have to send it for ER/PR, that is estrogen receptor and progesterone receptor status, and HER2 status, that is human epidermal receptor growth factors. Now, why this is so important? ER/PR positive and HER2 positive, because we are the ones who are going to help the oncophysician as in this management. If the tumor is estrogen and progesterone receptor positive, that means they have the receptor, the cancer cells, they carry the receptor on them, and they get attached to the estrogen and progesterone hormone, and they flourish further. So we have to have a therapy which targets to block the receptors. That means the hormone which blocks the receptors gets attached to it by competitive inhibition. So it prevents these receptors getting attached to the hormones, and that's how they prevent the further growth of this cancer. Human epidermal growth factor receptor 2 is also one more marker, and of course that decides the prognosis of this malignancy. So trastuzumab is the drug of choice for this treatment. All this treatment also involves gynecologists to start with, to follow up this patient on a long-term basis as well. Now, whom to offer genetic testing? Women who, this is a National Cancer Comprehensive Network recommendation that women who have family history of or known BRCA1, BRCA2 mutation, personal history of breast cancer, plus one of the following, that is, if the malignancy is diagnosed before 45 years, diagnosed at the age of 50 years with one of the more close blood relatives having pancreatic, colonic or prostatic cancer, or malignancy which is diagnosed after 60 years with triple negative breast cancer. So this is just to show you the BRCA1 and BRCA2 mutation. So right from counseling, making the awareness, teaching them self-breast examination, training our paramedics for breast examination, clinical breast examination, doing the clinical breast examination, diagnosis up to even tissue diagnosis, staging the woman for breast cancer, and of course referring timely to a proper authority or to a proper managing physician or oncosurgeon. That is what, and of course hormone therapy and follow-up. Everything involves gynecologists. So we have a major role as preventive oncologists. Hello. So what can we do for such patients? As I have already said, obesity puts you at a higher risk. So maintain healthy weight throughout life, optimize BMI, of course, have healthy food, lots of fresh vegetables, fruits, and lots of water, but not the caffeinated drinks like tea, coffee, soda, or energy drink. Limit your sedentary behavior, be always physically active, limit your alcohol and smoking, get screened at the age of 40 years or older, and 10 years earlier if you have high risk. Talk to your doctor regarding your breast cancer risk, regarding your medical and family history. If you are at risk, self-examination, clinical examination by 20 years, get your mammography and MRI done annually. I'm almost on the last two slides. What is the status? Do I have 1 or 2 minutes, Dr. Deepani?
Yes, madam.
Yeah.
Just 2 minutes more.
Thank you. Rather than blaming the government, are we supposed to do something? As I have already said, like cervical cancer, we do not have organized screening programs in India for breast cancer. They're almost non-existing, but our participation in this will matter a lot as far as the prognosis of breast cancer is concerned. The factors I have already said, non-participation of the women because of lack of awareness, lack of access to the healthcare facilities, and social as well as cultural taboos. If India lacks organized screening, we have the major role to play. I would go one step ahead and say that why to blame government, and just as responsible citizens of India and of course gynecologists, we are privileged. The women come to us for any of their problems for that matter, and we should utilize this window of opportunity and examine the breast of every woman and notify if she has any abnormality, teach her self-breast examination, and of course, if at all she finds any, if at all she finds abnormality, she has to report to you, investigate these women, diagnose them at the earliest, and do timely referral. That can definitely help her to improve prognosis of these women. So early detection saves lives. And friends, we are the saviors. Thank you so much. Once again, the team BOGS for giving me this opportunity. Thank you so much.
Thank you, Dr. Sneha, for a wonderful talk. And thank you, Dr. Tulika as well. Thank you, Dr. Mondal and Dr. Kalidas Bokshi for chairing the session. So as we don't have any question and answer in our chat box, in our question and answer box as well, we are moving on towards our second session where I would like to call the chairpersons, two prominent national Chakraborty, who has dedicated his whole life towards service of gynecological cancer patients. Dr. Jana, can we have sir's slide, please? Professor Chakraborty is the FRCOG FSCS. He's an ex-professor of Calcutta Medical College and distinguished professor of Government Medical College, Government of West Bengal. He is the president of our Kolkata Gynaecological Oncological Translational Research Group, or Colgo TRG group, which is being founded in 2 years back in Kolkata. And he has Lifetime Achievement Award in Oncology by Oncology Society of Bengal, by Sharoj Gupta Lifetime Achievement Award at SGCC and RI Thakurpukur, Kolkata. Welcome, sir. Our next chairperson is...
Panita,
Yes,
can I
sir?
add something as the president of the Bengal Society?
Yes,
Not
sir,
only
please.
Bimanda is never late for any meeting, he's been the chair of the Scientific Committee of AICOG 2007 and the advisor to the Scientific Committee of AICOG 2023. In spite of his age, throughout the pandemic, Bimanda has never stopped working even for a day. And he still goes to Thakurpukur Cancer Hospital and has his OPDs, and he does his surgeries, and he's an inspiration and a living legend and an example for all of us.
I totally agree with you, sir. And he drives his own car also. So, next slide, please. Dr. Rahul Rai Chaudhary. Our next chairperson, he is an FRCOG and PG certified medical education from Brighton University. He's a consultant gynecological oncologist of West Bengal. Sir, Dr. Biman Chakraborty and Dr. Rahul Rai Chaudhary, please proceed. Thank you.
Am I audible?
Yes, sir.
May I have the CV of Dr. Bhagalakshmi, please? Yes. She's Dr. Bhagalakshmi Nayak. She's from our neighboring state. She's MD, FRCOG, PhD, Associate Professor, Department of Gynecology and Oncology, Chairperson, Oncology, Governing Council Member, Vice President, AOIGN, Joint Secretary, AGOI, Executive Member, ISRO, FOGSI, Oration, and Dr. Abha Singh, Oration, Assistant Editor, Indian Journal of Oncology, and peer reviewer. That's a big list. And Dr. Nayak, the floor is yours. Your subject of discussion is very interesting. It is very much close to my heart. Please continue.
Thank you, sir, so much. It's really a pleasure to have you as one of my chairpersons. And so can I share my screen? So thank you so much again. It's really a pleasure sharing the dais with so many VIPs today, all teachers and teachers of teachers. So that I can say. So I think my screen is visible, Dipanvita?
Yes, madam.
Okay. So I begin really by thanking Bengal Obstetrics and Gynaecological Society for giving me this opportunity. And I think it has been a real trying time for all of us in this pandemic. But I think if you look at the better side, we have learned a lot in this pandemic because there have been too many good programs which we would have missed whether in real life without a pandemic and a lockdown. So thank you again. I bring you greetings from my land of Lord Jagannath. So my topic today is optimal surgery in ovarian cancer. So I think that's not a very easy thing to cover in 15 minutes, but let me see, try out. So surgery for ovarian cancer management is that's the cornerstone of management. So that can be basically divided into basically two groups. One could be a primary surgery, the other could be a secondary surgery. So again, in primary surgery, if we are doing it for a limited disease or early stage disease, it could be a surgical staging or a conservative surgery. Suppose she is an unmarried girl or she's has not completed her family. But for advanced disease in stage 3 and 4, it's always a cytoreductive surgery, otherwise called a tumor reductive surgery. There's another group called a secondary surgery, which includes interval surgery called a IDS or interval debulking surgery. or a second look laparotomy, or a secondary TRS, or a palliative surgery. So these are the 4 kinds of surgery which we could also have in the secondary group. But as of now, the second look laparotomy has really no role in the field of very good imaging and very good tumor markers. But secondary TRS may be required in recurrent settings, and palliative surgery may sometimes be required, because all of us know that ovarian cancer is not a good disease. Sometime or other in the course of the time, they develop chemo resistance, and then intestinal obstruction is the commonest cause of death in ovarian cancer. So some kind of palliative surgery in the form of stomies would be required. So as we have to remember that the dictum of managing ovarian cancer is always a midline vertical incision, and it should be little liberal. So it's not necessary that we look at the cosmesis here, because we need to give a good life to the patient, and maybe most of the time we would need to extend it beyond the umbilicus, or especially when there's an extensive omental disease, or we do a proper adequate para-aortic lymphadenectomy, it could go beyond that up to the xiphisternum sometimes. So coming to early stage disease, staging laparotomy, or it's called staging laparotomy or surgical staging. It's always again a vertical midline incision. You evaluate whether there is ascites. If there is no ascites, you collect some peritoneal washings from the paracolic gutter, from undersurface of the diaphragm, from the pouch of Douglas, and a complete abdominal inspection and palpation is very, very important, because if you miss a small nodule on the diaphragm, that's a really advanced disease which will be missing out, and maybe we bar the patient from having the adjuvant chemotherapy. So excision and biopsy for all the suspicious areas or lesions, multiple intraperitoneal biopsy. If you don't find any lesion also, it's prudent to take multiple intraperitoneal biopsies. So ultimately it culminates into a total abdominal hysterectomy, bilateral salpingo-oophorectomy, infracolic omentectomy, and selective lymphadenectomy and appendicectomy. Though appendicectomy is now a very dubious thing to do or not to do, there are many guidelines which tell that only the appendix should be removed if it is diseased or in mucinous tumors. So and then coming to selective lymphadenectomy, I think again that's again a little confusing thing, because some papers tell that we need to remove the bulky nodes. So what does bulky nodes mean, and how do we assess them? Because in imaging they may all be negative, but we have to open the retroperitoneal space to find out the bulky nodes. So, and it's so important that we do the lymphadenectomy even in early stage disease, because 20 to 30% of the early stage disease will have positive lymph node, and that will automatically upstage the disease, and she will need adjuvant chemotherapy. So this THBSO may not be a fact if you are going to do a fertility preservation, though all the steps have to be done, but preserving the uterus and the other side of the ovary if that's normal. So at the end of the surgery, we will have both the ovarian ovaries, we'll have the uterus, we'll have the peritoneal washings, and we'll have all the nodes and the appendix if it is diseased. So then coming to conservative surgery, so the criteria to be fulfilled are fertility preservation should be the goal. We have to take a consent from the patient, because she should know that this is a little risky thing that we are going to do. There's always a risk of the disease coming back. So it has to be, she has to be counseled proper for a proper follow-up also, and there should be no evidence of dysgenetic gonads, especially in the germ cell tumors, because dysgenetic gonads are very prone to having the same tumor in the other ovary again. So special situations where this can be done is a unilateral germ cell tumor, unilateral sex cord stromal tumors, and unilateral borderline tumors. So, and stage 1A, 1C, 2A, and appropriate epithelial cancers with appropriate counseling, because epithelial carcinomas are very prone for coming back again as compared to the germ cell tumors and sex cord stromal tumors. So the procedure is a meticulous surgical staging, negative peritoneal washing, and a negative omental biopsy. Usually it is a unilateral salpingo-oophorectomy of the affected side. The unaffected ovary may be spared from biopsy because It leads to adhesions, ovarian failure, and mechanical infertility. I think Dr. Nandita is a pioneer in this, and she'll talk to us about that. And biopsy may be done if suspicious. And in case you really think that you need to do a biopsy, it's always better to cover it up with interseeds so that we avoid the adhesions. And ovary conservation in epithelial ovarian cancers should counsel the patient to undergo removal of these after childbearing. So germ cell tumors of the ovary are a very bright thing in ovarian cancer. They are very, very curable cancers, and usually they go ahead cured and can continue their family. So this is one of our patients. Here you can see that when she was young, the uterus is so small, the ovary, this side ovary is normal, but this is a huge tumor. But then she has been cured completely and has completed a family now. So out of all the ovarian tumors, germ cell tumors, dysgerminoma is the commonest variety, but and this is highly chemosensitive and radiosensitive also. But the only thing about dysgerminoma is that they have a bit of lymphotropism. That is, they have a chance of lymph node metastasis, more common than other germ cell tumors. So for germ cell tumors, palpation again of the pelvic and para-aortic lymph nodes is recommended among surgical procedures required for adequate staging, especially in dysgerminoma because it has a bit of lymphotropism. An exception might be very early germ cell tumors without indication for an adjuvant chemotherapy. If you are thinking that it's a very early adjuvant germ cell tumor and you don't need to give her a chemotherapy, and in those cases, I think it's ideal to do a at least assess the retroperitoneum for enlarged or bulky lymph nodes. Although routine lymphadenectomy has not been introduced in international consensus for the germ cell tumor, it should at least be implemented in patients with dysgerminoma and mixed germ cell tumors because sometimes they do recur in the lymph nodes later on. So coming to omentectomy, whether that's necessary or not necessary for germ cell tumors, I think studies have shown that omentectomy in patients with clinically early stage germ cell tumors may not improve patient survival and may be omitted. But at the same time, having said that, I would tell that it's always ideal to take a omental biopsy and not leave it alone. So sometimes you would get cases, especially in gynae-oncology, we get cases in which unilateral salpingo-oophorectomy has done and she has come with a biopsy report of a germ cell tumor. So what about the restaging in these patients? So what do you do with these patients? So there are some guidelines. If it is a pure ovarian dysgerminoma, prognosis is excellent. So conservative surgery with a complete surgical staging is the gold standard. Everyone will agree with that. But then if the patient has come to you after a unilateral salpingo-oophorectomy, patients with incomplete staging could undergo surgical restaging. That's the option. But surveillance can also be done because they are very chemosensitive tumors. We have good imaging. We have good tumor markers to follow them. And chemotherapy should be reserved to relapse with excellent chances of therapeutic success. So whenever a patient comes back to you with a unilateral salpingo-oophorectomy, please don't jump immediately for a restaging because that's very traumatizing to the patient also. So in cases of recurrence, about 75% of the recurrences could occur in the first year after initial treatment. So we have to counsel them for a proper follow-up, and the treatment is chemotherapy. But there is a role of secondary surgery even in recurrent setting, and it is usually in immature teratoma and who underwent secondary surgery was superior to those with other histologic types, particularly in patients presenting with growing teratoma syndrome. Ideal candidates for such consideration would be those with an isolated focus or limited foci of recurrent tumor. If there's an isolated focus, and very rarely there would be a chemo-resistant focus also sometimes, and they would need some kind of surgery. And the most common sites of recurrence are in the peritoneal cavity or in the retroperitoneal lymph nodes. So summarizing germ cell tumors, surgery should be unilateral oophorectomy, peritoneal washings, omental biopsy, and selective removal of enlarged nodes. Biopsy of a normal contralateral ovary is not indicated. Surgery should be by open procedure to enable removal of the affected ovary with its tumor intact rather than broken or ruptured. There is no role of systematic lymphadenectomy in germ cell tumors. For women who present with advanced disease, consideration should be given to neoadjuvant chemotherapy to help preserve fertility and reduce the complexity of subsequent surgery. So coming to ovarian germ cell, sex cord stromal tumors, patients can be as young as 6 years old where fertility conservation is a real issue. So here again, this includes peritoneal biopsies, omentectomy or omental biopsy, resection of grossly suspicious pelvic or parotid lymph nodes, especially in the high-grade tumors. Careful inspection of the peritoneum is critical because residual disease is strongly correlated with recurrence. There appears to be little benefit to performing routine lymphadenectomy in the absence of grossly suspicious lymph nodes. So following careful surgical staging in the absence of extra ovarian disease, conservation of the uterus and contralateral ovary is reasonable. For older patients, THBSO is indicated. And in advanced juvenile granulosa cell tumors, they are treated with cytoreduction and chemotherapy, leading to prolonged disease-free intervals and multiple pregnancies. The uterus can be preserved, and sometimes in advanced, they may present with advanced disease. Cytoreductive surgeries can be done, and the value of secondary cytoreduction continues to be controversial, though, because they always have a chance of recurrence very late, and there is a role of repeat cytoreduction in these patients as well. So coming to early epithelial ovarian cancers, I think whenever you are opening a domain, I have already stressed about the vertical incision. If you are in a doubt, it's always better if the markers are not matching, your imaging is not matching, you are in a doubt, it's better to send the patient the specimen for a frozen biopsy. In case you don't have a frozen biopsy, you can also send her for a imprint cytology on the table, and that will guide you in the management. So in case that's proved that it's a malignancy, it inculcates with a THBSO, vomitectomy, peritonectomy, PLND, and a para-aortic lymph node dissection, so that at the end of the procedure, we don't leave anything behind. So what we remove is not important. What we leave behind is more important. That will decide about how long the patient is going to live. So omentectomy can be infracolic, supracolic, or total. Infracolic is the greater omentum below the transverse colon. Supracolic is the part of the greater omentum between the transverse colon and the greater curvature of the stomach. And the total is removal of the omentum, which extends to the hilum of the spleen in addition to the supracolic. So I think it's not always necessary to do a total omentectomy in early stage disease, because as we will understand that studies have shown that if you leave the omentum behind in cases where there is recurrence, the omentum actually covers and tries does not allow the cancer cells to spread into other parts and tries to engulf them. So limited omentectomy is desirable in early disease when the omentum looks very healthy. And it's so important to cut the uterus after the procedure, because many times we could have synchronous ovarian and endometrial cancers. So coming to lymph node dissection, I think that's a real controversial area. So, but the rate of positive lymph nodes in patients presumed to be in early stage is again 15%. And you can see that even in a unilateral tumor, the contralateral lymph nodes may also be involved. That again depends upon the grade of the tumor. So, lymphadenectomy in early stage is a part of the surgical procedure. It may be avoided in expansile mucinous carcinoma and non-epithelial cancers. But again, in mucinous, if you have an infiltrative variety, it's ideal to do a lymphadenectomy. And even in unilateral epithelial ovarian cancer, you need to do a bilateral lymph node dissections. And coming to para-aortic lymphadenectomy, that's again a trick which all you have to learn. And the NCCN guidance tell that what is the adequate lymphadenectomy? So at least 25 to 35 pelvic nodes and 12 to 25 aortic nodes. So it's not cherry picking. It has to be done in systematically. So a complete surgical staging, including systematic lymphadenectomy, should also be performed in patients with fertility preservation. Even if you are doing a fertility preservation, you have to do a lymphadenectomy. And coming to borderline ovarian tumors, again, the positive lymph nodes are around 7 to 23%. So along with the proper staging, you need to do a lymphadenectomy in select cases. And so, but it does not have a very prognostic value though. The procedure should only be reserved for cases with enlarged or bulky or clinically suspicious nodes. And again, let me remind that clinically suspicious nodes can only be detected if you open the retroperitoneum and explore the para-aortic and the pelvic spaces. So coming to advanced epithelial ovarian cancers, the surgery is called a tumor reductive surgery. The optimal residue is less than 1 to 2 centimeter and suboptimal is more than 2 centimeter. But the goal, again, I reiterate, should be a zero, leaving behind no gross residual disease. So the benefits are improvement of the tumor response to further therapy, removal of all large tumor and omental cake, reduces ascites, prevents bowel obstruction, enhances immunological competence, and psychological relief, of course. So the procedure is again a midline incision, explore properly, all primary tumors and disease should be removed. Radical oophorectomy is the name of the procedure in which a retroperitoneal approach is taken to remove all the pelvic extension of the ovarian cancer into the sigmoid and into the pouch of Douglas, into the parametrium and up to the pelvic wall. So a total omentectomy is ideal. The resection of the rectosigmoid, small intestine, splenectomy and hepatic resection may be required as the case may be. Peritoneal stripping, including the diaphragmatic stripping until you get R0 with extensive peritoneal implants and a resection of the retroperitoneal nodes. So here is a case in which you can see that there's a huge deposit on the sigmoid colon. And in this case, if you do not go retroperitoneally, you will never be able to resect this tumor. So this is called a retrograde hysterectomy, in which the peritoneum on the sigmoid is taken along with the uterus, and this is done by opening the vagina first on the anterior lip, then opening the posterior lip, posterior layer of the vagina, and taking the peritoneum along with the uterus. So at the end of the procedure, you have in the pelvis something like a retroperitoneal dissection, as we do for one-time cystectomy. So this is again a retroperitoneal approach in which the peritoneum is removed along with the uterus. So here you can see that it looks something like a bat. So if there's a sigmoid colon is involved, you would need to remove the sigmoid colon and leave back a colostomy in case you are not able to anastomose that. So radical oophorectomy is a process in which the removal of all the pelvic tumor is termed as radical oophorectomy, and usually it is a retroperitoneal approach. And here you can see that it has been removed and blocked with the uterus, ovaries, and involved sigmoid colon. So the motto of everything is that we remove as much as possible, because what we remove does not decide about the fate of the patient. What we leave behind actually decides the fate of the patient. So treating advanced ovarian cancer is a real challenge to the surgeon. From a surgeon's perspective, advanced ovarian cancer is more a peritoneal disease rather than a retroperitoneal disease. So we have many predictive models and strategies, because the surgery is going to be a little tricky to decide whether to go for surgery, or we have chemotherapy in hand, give them chemotherapy and downstage the disease and then go ahead with surgery. So this is a score called the Sudan score, in which we have so many factors to look at. We have got a FOGSI score by which we can do a diagnostic laparoscopy and then decide upon the score as to whether to go ahead with the surgery or to give chemotherapy and then settle for the interval debulking surgery after 3 cycles of chemotherapy. So again, in advanced disease, we could have a huge omental cake, and I think it may not always be so easy to remove as compared to this case, in which though there is omental disease, it's easier to remove. So the limits of omentectomy, any macroscopic involvement of the omentum is part of the objective of complete cytoreduction. There is limited evidence that a total omentectomy with the objective to remove an unrecognized occult disease in the infragastric omentum benefits the patient. So if it's a omental cake, we have to remove the total omentum. But if there is not much disease, it's better to do a infracolic omentectomy. So there are complications with omentectomy also. We could have some heavy bleeding sometimes, gastroparesis, stomach or transverse colon injury, and possible sometimes a splenic injury, or if you're doing a very total omentectomy, you could land up in injuring the tail of the pancreas sometimes. So coming to lymph node again, so patients who did not undergo optimal cytoreduction would not benefit at all from lymphadenectomy. So in advanced cases, if you have done a R0 resection, it's ideal to go ahead and do a lymphadenectomy. But patients with complete or almost complete debulking and bulky nodes could benefit from removal of enlarged metastatic nodes by reducing macroscopic residual tumor. And again, patients with complete or almost complete debulking and with clinically suspicious nodes might not change the residual disease status, but may reduce the tumor burden, which is not optimally accessible by chemotherapy. So this is the lion trial, which has shown that systematic pelvic and paraortic lymph node excision in patients with advanced ovarian cancer with both intra-abdominal complete resection and clinically negative lymph node neither improve overall nor progression-free survival despite detecting and removing subclinical retroperitoneal lymph node metastasis. Data in this study indicate that systematic lymph node excision of clinical negative lymph node in patients with advanced ovarian cancer and complete resection should be omitted to reduce postoperative morbidity and mortality. But the consensus guidance from NCCN shows that if you decide on a lymphadenectomy, it has to be a paraortic with pelvic, and this paraortic lymphadenectomy should be up to the renal veins. So that's the important structure that we should maintain. Indications of splenectomy are very limited. If it is the spleen has a metastasis, or there is perisplenic tumor infiltration, or you have had an intraoperative trauma to the spleen, which bleeds profusely sometimes, you may need to do a splenectomy. However, all tumors, this is a study from JGO which show that distal pancreatectomy with splenectomy for the management of splenic hyalometastasis in cytoreductive surgery of epithelial ovarian cancer is a feasibility, and we can do it, but then depends on the setup in which you are working. So coming to the CC score, what is CC score? We should know this. CC is the completeness of cytoreduction score, is estimated by the surgeon following debulking surgery and refers to visually determined removal of all visible peritoneal deposits. So our aim should always be to be a CC 0, that is no tumor left, and that's the golden thing that we could do. So then coming to interval cytoreductive surgery, because it's very complex to do advanced epithelial ovarian cancers, in case it's not possible to do in your center, please don't handle the case and do an incomplete surgery and leave her alone. So we have to decide that there are some indications in which we could give 2 to 3 cycles of chemotherapy, and these are the indications for that. If it's a very fixed mass, there is liver metastasis, pleural effusion, you can give her chemotherapy. You can always score the patient. It's the Mayer score by CT scan or a Fagotti score by laparoscopic, and decide whether you can do a CC0 or not. So in those cases, I think there is an indication for giving neoadjuvant chemotherapy, and the other things which you can see by laparoscopy which would negate a primary surgery are root of the superior mesenteric artery involvement, splenic hilus or ligaments involvement, lesser sac disease, gastrohepatic ligament or portohepatitis disease, or a gallbladder fossa disease. So I think we should take a call on whether I will do it or I will not do it. So NSAT has got its role. Patient condition much improved with neoadjuvant chemotherapy, and it's a less morbid surgery, takes a less time and less blood transfusion, and there is no difference in the survival. So advantage is that it's the quality of life improvement is better, and the mortality and morbidity are almost the same. So these are the two trials, the URTC and the CHORUS trial. We show that neoadjuvant chemotherapy has been proposed as an alternative in advanced epithelial ovarian cancer patients with low performance status, underlying morbidity, older age, or disseminated unresectable disease. So this is again a Scorpion trial which has shown that you can assess it by laparoscopic predictive index, and the progression-free survival is almost, and the overall survival is almost the same, and so there is no much survival difference in the two groups. Then a bit about recurrent ovarian cancer. Approximately 70 to 80% of patients with advanced ovarian cancer will relapse with first-line chemotherapy, and because theoretically sometime or the other they will have some kind of drug resistance, and so the advantages of surgery would be to overcome drug resistance, increase drug perfusion, increase the growth fraction of the tumor cells. So we have 3 randomized controlled trials evaluate the role of secondary cytoreduction surgery, and various models have been taken to pick up the patient who would have some advantage with these surgeries, and surgery has been shown to be beneficial if you could do a complete gross resection. So here we can see that the graph show that there is a benefit if we have been able to do a complete gross resection. So we have to pick those cases which are very carefully so that we give them a good quality of life. So summarizing, in assumed early stage, only thorough staging surgery can confirm an early stage disease So no radiological workup is equally effective. So that I think thorough staging imaging cannot replace thorough staging. In advanced stage, complete resection of all visible disease is the most important first step of treatment and a potential cure of the patient. And benefit of cytoreductive surgery is removal of vascularized tissue and chemoresistance clones that will later become responsive. So the moral of the story is that the first surgery is the best surgery. Now we are heading more towards conservatism and fertility preservation. And believe me, friends, the time spent in OT ultimately translates to the years in life. So give time to your quality time to your ovarian cancer patients. Do not hurry when you are opening a case of ovarian cancer, because all those hours will translate into years. So then the the $1 million question is who should operate? So I think we'll have some dispute about that though, but this is evidence. Appropriate staging done 97% if staged by a gynecologist, 52% if staged by general obstetrician and gynecologist, and 35% if staged by a general surgeon. So, and studies have shown that the prognosis has been better if surgeries are performed by trained gynecologist. So thank you very much for a patient hearing and giving me this opportunity.
Thank you,
Thank you
madam.
very much.
Thank you. Yes, just to, because of time constraint, I would request to the faculty, Dr. Bhagya madam, just to go through the question and answer box and the chat box as well. There are 2 questions regarding your presentation.
Okay.
If you can address them on the chat box.
I'll do the needful. Okay.
Thank you.
Thank you so much.
Vimanda wanted to say something. Vimanda?
Yes, I was just appreciating the talk, but she had mentioned that there's the optimal reduction. Well, that is where the point is. What is optimal really? Because can a molecular disease can be completely removed? It is a doubt, and that is always bothering us. It is only the visual interpretation that we see, that is, we have removed everything and we feel happy that we have done it. Okay. That is why, as the days go by, I find that oftentimes it is much better to do the initiative first and then about it. And we have been able to resect and remove the materials which we could not think of removing before. The other point is the colostomy part. And Indian women do not accept colostomy, permanent colostomy, because she has to go to the wash it, to mandirs, etc. Therefore, it has become very difficult to convince them. Therefore, when there is a risk of doing a colostomy, it is much better to go for a anesthetic and then for the removal.
Thank you, sir.
Thank you very much.
Thank you. Good morning, everybody. Can I now introduce the next speaker, please? Can I have the slide? Can I have the CV slide, please? Thank you. It is my proud privilege to introduce Professor Krishnendu Gupta, who is the professor and the unit head of Department of Obstetrics and Gynecology, Vivekananda Institute of Medical Sciences, Kolkata. He's an adjunct professor. He's actually told me strictly not to read out the rest, so I will actually let the audience have a look at it. Let me just call on Professor Krishnendu to start deliberating on HPV vaccination. Are we really doing enough? Professor Krishnendu, the floor is yours.
Thank you very much, Dr. Rahul. My respects to Professor Biman Chakraborty and all the teachers in the audience. Is my slide visible and am I audible?
Yes.
Right. So the topic that I've chosen is HPV vaccination. Are we really doing enough? Well, we all know that prevention is better than cure, and we know that we could eradicate smallpox. And through the efforts, we are managing to slowly weed out polio from our earth. So I think it's time now to prevent and eliminate cervical cancer. 1 woman dies of cervical cancer every 2 minutes. Each one is a tragedy and we can prevent it. So said Dr. Tedros. who's the Director General of WHO in May 2008. And he also said that together we can make history. It is within our reach. So it's often said, and there's a famous quote by George Bernard Shaw, that opinions often appear first as jokes and fancies, then as blasphemies and treason, then as questions open to discussion, and finally as established truths. So are we really going to make it happen? So we all know about the HPV virus, the human papillomavirus. I'm really not going to deal details on them. We've heard enough till ad nauseum. There are 100 types, 30 types target the genital mucosa, 14 types are oncogenic. But the problem is with the new cases surging again. 604,000 plus cases. Of course, COVID has taken over, but there are 314,000 plus deaths as well. So cervical cancer ranking 4th leading cause of female cancer deaths in the world, and the 2nd most common female cancer deaths in women between 15 to 44 years in the world. And more than 90% of HPV cancers in women are cervical cancers, and the highest amount of cervical cancer incidence rate is seen in Swaziland, which is a country in the southern part of Africa, a very, very poor country indeed. Now, all of you must be wondering, why have I put up this aircraft picture, an Airbus A320, which when we were flying in the non-COVID time, was one of the commonest aircrafts we were flying. And I'll come to this in a minute. Look at the chilling truth about this situation in India. When we started talking about the burden of disease, Globocan 2010 showed 132,000 new cases with 72,000 deaths. Came in Globocan 2012, actually the incidence started reducing to 122,000 and 67,000. Globocan 18 came, we were extremely happy, almost 97,000 new cases and 60,000 deaths. But look at Globocan 2020. We are back to the 2010 status, 120,000, almost 124,000 cases and 77 plus thousand deaths. So basically we are back to square one, 212 deaths per day, 9 deaths per hour, 1 death every minute. So that means that an Airbus A320 is crashing every day in our country, if not more than one Airbus. And we are doing nothing about it when 1 in 4 who die globally is an Indian. So we all owe a great deal to this great man, Professor Harald Zurhausen, whose team said that persistent infection with oncogenic HPV is the necessary cause of cervical cancer. He also showed the strength of association between HPV-16 to cervical cancer and was awarded the Nobel Prize for Medicine or Physiology. And I would love to stick my neck out and say that our orator today should be the second one to get this award for his work in HPV. We all know that the natural history of HPV infection, how it occurs. The main idea is that we cannot allow cancer to occur to know whether a medication is working. So we have to have surrogate markers, and the surrogate markers are those which can prevent a SIN1 to SIN2, SIN2 to SIN3, and then get into cervical cancer, and that is our vaccination. And if we can prevent this, we know that the vaccination works. So the strategies are cervical cancer and are screening and vaccination. And I have this acronym called as SAVE, which is screening, awareness, vaccination, and we also have to educate. Education is extremely important. As in any vaccines, the commonest questions asked are, is it licensed? Is it efficacious? Is it safe? How many doses, if any? Booster if required? Is it available? What is the cost? And whether it is recommended by all the bodies of the world, the WHO, ICOG, RCOG, RANSCOG, FOGSI, etc. And I must say that the HPV vaccines are not only licensed in our country, they are efficacious, they have proven to be safe. We need 2 to 3 doses depending on the age. They are freely available except one in India. The cost is, of course, a little high at the moment, but of course, with use, it will come down, and it is recommended very strongly by all the national and international bodies. But what is most important is counseling. We have to we have to give time to counsel and overcome these barriers, which are often in the society. We have to educate not only ourselves, because a lot of the doctors themselves are not still convinced after so many years of its study. Healthcare providers, counseling the parents, the vaccinees themselves, and of course, the adolescents. And the strategy for adolescents is 3 A's: awareness, access and availability. We have to make them aware. We have to have it accessible to them, and of course, availability. And I always say that charity begins at home. When will you vaccinate your daughter or niece or a loved one? And that is the question. If you don't do it yourself being a doctor, how can you expect parents and other people in the society to accept it? We know the composition of the two vaccines, the ones which are available in our country, Gardasil, which contains the VLPs of 6, 11, 16, and 18. 6 and 11 is for warts, and 16 and 18 is the oncogenic variety. Cervix is the bivalent vaccine, 16 and 18, with a novel adjuvant called as AS04. Well, depending on the age group, as we said, 3 doses. Gardasil is 0, 2, and 6. That is 0, 2 months, 6 months. Cervix is 0, 1, and 6. If the age is more than 15, if it's less than 15, 9 to 14, of course, we can give 2 doses, 0 and 6 for both the vaccines. Both the vaccines are highly efficacious. They prevent changes from SIN2 to SIN3 in 100% of cases. Gardasil, the quadrivalent vaccine, also has an added protection against vaginal and vulval intraepithelial neoplasia, and also protects against genital warts. And there is, of course, cross-protectivity against the non-vaccine oncogenic types, 16 with 33 and 31 and 33, while 18 with 45 in the vaccine. Cervix is a little better with the cross protection on that. And of course, the Patricia trial, which is the papilloma trial to prevent cervical cancer in adults, has shown that in a TVC naive group, irrespective of DNA in the lesion, they showed a 93% efficacy. That's really, really humongous. And I think we should be very happy to get such studies. Well, about pregnancy, a common ask FAQ. It's not recommended, of course, in the use in pregnancy. If the first dose is taken, the other 2 can definitely be delayed till the completion. And no pregnancy test is actually required before the vaccination. And if a vaccine dose has been administered, no intervention is needed. That's the most important thing we must know. We should not, get an MTP done or something like that. That is just not on. No intervention. So the 2-dose schedule between 9 and 14 is definitely a welcome news. It has the potential to lower costs, increase vaccination coverage rates, and improve cervical cancer protection worldwide. Well, the one which is newly licensed in India but not available is Gardasil 9, the nonavalent vaccine, with VLPs of 6, 11, 16, 18, 31, 33, 45, 52, and 58, with the same adjuvant as in the quadrivalent vaccine. Well, it has the potential increase the coverage protection from 70 to 90% of cervical cancers, and the immune response is found to be similar with that of the quadrivalent vaccine between the age group of 9 to 15 years. And the safety profile was similar when compared between the quadrivalent and the nonavalent vaccine. So coming to the global scenario, it is a dismal situation in the less developed countries. It has been found that in the developed regions between the age of 10 and 20 years, 33.6% of the population were females were vaccinated, while it's only 2.7% in the less developed countries. So you can imagine why the rate of incidence is going up and up and up. And there's limitations of the first generation vaccines as well in the developing countries: high cost, 3-dose schedule, uncovered HPV types, and of course it has got no therapeutic benefit. So WHO launched on the 17th of November 2020 the launch of the global strategy to accelerate the elimination of cervical cancer. And Dr. Tedros said this is a global event. And they had the 90-70-30, 90-70-90 targets, which was 90% of the girls should be fully vaccinated with the HPV vaccine by the age of 15 years. 70% of women are screened with a high performance test by 35 years of age, and again by 45 years. And 90% of women with cervical disease, they should receive treatment and, of course, hope for their recovery. So basically, this is the vision of a world where there'll be cancer. It's a cervical cancer-free world, and a threshold of 4 per 100,000 women years to eliminate is definitely a public health problem, but I think we should be able to get there with our effort. A note for the postgraduates: an extremely good ICOG committee opinion paper on the human papillomavirus. It has got 12 recommendations, which was published in August 2020, a must read, beyond the scope of this presentation to go through all the 12 recommendations. But I think I would urge you to go through this lovely presentation. So coming to India, the National Technical Advisory Group on Immunization gave the green signal to be included in the national program, but unfortunately, Even now, it has not happened. Maybe because of COVID, everything has got delayed. But so blame it on COVID, like blame it on Rio, blame it on COVID. So I guess that's the situation as we are right now. But there is a study that we can actually eliminate cervical cancer in India by the year 2079. Well, Make in India, Zydus Cadila is one of the vaccine candidates for a HPV vaccine. And the other one is, of course, the one from Serum Institute of India. I think all these have again taken a backseat because of COVID. Phase 3 trials are going on, and we have very, very erudite speakers here and people like Dr. Ranjit Mondol, Dr. Deepanita Banerjee, who have done studies on this. So I think they will be able to highlight on how the project is going on, the study. Well, I found this lovely paper way back written by Professor Shankar Narayanan way back in 2016, where he showed how safe these vaccines are, that more than 280 million doses of HPV vaccines have been administered worldwide with excellent safety profile, with no serious adverse effect linked to it. And it's really lovely that we have such a great man giving the oration today. So what's the scenario in India? We know that the Drug Control Journal of India has approved both covalent vaccine is not yet available in our country. It's not yet been launched because of certain logistical issues. Delhi was the first state to launch the HPV vaccine as a public health program. The two other states are Punjab and Uttar Pradesh, which of course didn't take off well. And there are professional organizations like FOGSI, Indian Academy of Pediatrics, ICOG, to support its introduction in the National Immunization Protocol. The NGOs like Rotary, which I'm going to speak on, and individual effects play a big role in advocating this vaccine. And of course, these will never, ever replace cervical screening programs. So cervical screening and vaccination must go hand in hand. So a little bit about Rotary International, because I'm associated with Rotary. We had ongoing small batches of HPV vaccination through our club. Since 2009, I had taken an initiative on that. But the major initiative came in the pilot project in 2017-18 with the help of the Chittaranjan National Cancer Institute, headed by the then director. But also we had Deepanita and Dr. Ranjit Mondol. Here's Deepanita along with the Rotarians, where we vaccinated 555 adolescent girls. And this was a totally self-sponsored project. We had more than 98 girls who received the second dose. And I'm glad to say that the project was inaugurated by none other than Professor Shankar Narayanan, who, despite a loss of a parent a week ago, came from Coimbatore, and I get emotional when I speak this. He stuck to his word, came and inaugurated this lovely project, and we have not kept quiet, sir. We have moved forward, and you'll be happy to know what I'm going to share with you. So we not only did this project with the help and the permission of, and I'm grateful to Dr. Ranojit and Dr. Deepanita for this, we published, I presented this at the FIGO Rio de Janeiro conference, where we did a study called as the feasibility, accessibility, and safety of the two-dose quadrivalent vaccine in 555 adolescent girls in rural India. Well, I'll tell you, everybody gets upset when your paper is not accepted for oral presentation and is accepted as poster. But I used it as my advantage, and I'll tell you why. We had this, we shared the learning objectives, the methodology, how we got about it, the eligibility, exclusion, inclusion criteria, demographic profile, and of course, the analysis of the results, where we showed a 98% follow-up for the second dose. And we proved that when we join hands with reputed and reliable, trustworthy NGOs, we can make HPV vaccine programs most sustainable within the context of a comprehensive approach to cervical cancer prevention and control. And thanks to this poster, I could have Bhaskar, Shanta, Basho, Ali Wright, Fiona McAuliffe from Ireland, Cleona McAuliffe, then we had Rohana Hatatua and of course, Jeannie Connery, Sir Arul, Professor Skiara, Marianne Lumsden, all coming and actually knowing what we are doing about cervical cancer vaccination. And so we did not stop there. This is for Professor Shankar Narayan. We went and got a global grant through Rotary for $80,000, two global grants, $80,000 and $55,000, where again, thanks to Dr. Ranjit Mondol and Dr. Deepanita Banerjee and the director of CNCI, we did a phase 1 study, hoping to do 1,000 girls and then 750 girls in the second phase with the bivalent vaccine. And we completed 1,150 girls instead of 1,000 girls. The phase 2 was supposed to start last year, got delayed because of COVID. We was planning to start it mid of this month, but again, it's obviously got delayed because of COVID again. And this is how it started. You see the commitment of Ranojit, Dipanita, along with us Rotarians. Of course, I'm a doctor too, but then we also went together to all the villages where we had the community assessment programs. And of course, I took part in the vaccination. And even in this pandemic, in 21st of February, we had Dr. Ranojit coming all the way to almost 3 hours out of the city to a small place called as Piali, where we had a cervical cancer. And again, here you have Dr. Ranojit giving the message to all the parents and the girls who are going to get vaccinated, and the team from CNCI giving the vaccination along with the district governor who took it over, Mukul Sinha. So the single dose vaccination, which I'm sure Professor Shankar Nayan will be speaking on, encouraging robust antibody titers, whether they'll be comparable with the 2 and 3 dose is yet to be seen. And if it's a single dose that we can think of the future, it may offer a very easy and cost-effective vaccination program, especially in the lower and middle income countries. The second generation prophylactic vaccines also are being improved by having alternative viral components and also better cost-effective strategies of production. But again, due to COVID, I think everything's now shifted, gone back, everything's under standstill. And we have E. coli-based, Pastoris-based and other vaccines coming up, which I'm sure will be handled by the experts as far as the vaccines are concerned. There are therapeutic vaccines like the GS188E from Korea coming up. They have found it to be quite an effective one, even in metastatic disease. And they have now recently, in December, they published a paper of the pembrolizumab, which was added to the therapeutic vaccine, and they're doing studies in it and showing some good results. So this is a famous saying. We use it in so many ways, that women are dying because societies have yet to decide whether their lives are worth saving. And this is by our past FIGO president, Mahmoud Fatala from Egypt. We all know that vaccines are important, but vaccines don't save lives, vaccination does. So when we want to vaccinate, we must counsel, and we must talk precise, short, meaningful words, not give some big garb about science. We must talk quickly, short and sweet, crisp, talk emotionally, give some small stories about how you could help this one, how you could help that one. I have vaccinated my daughter, I have vaccinated my niece, and stuff like that. So it should be short and succinct, elevator-like speeches. But more importantly, I think the recommendation must come from us, you the doctors, you who know about the subject. It should not be some Tom, Dick, and Harry speaking about the vaccine. We must recommend it. So again, I repeat, prevention is better than cure. We have to be more curious about our daughters, that is by vaccinating. We have to be curious about their future, so we continue screening. We must be concerned about our mothers, especially today being Mother's Day, by detecting early disease and treating them. And I'll end with this lovely statement by, again, Dr. Tedros in the Global Strategy to Eliminate Cervical Cancer. He says that through cost-effective, evidence-based interventions, including human papilloma vaccination, virus vaccination for girls, screening and treatment of precancerous lesions, and improving access to diagnosis and treatment of invasive cancers, we can eliminate cervical cancer as a public health problem and make it a disease of the past. And I hope all of you here will work hard towards this. We have a vaccine, the only vaccine we have as a gynecologist to do something for the women of our country and the world. Orations, presentations, lectures, webinars on HPV vaccines are definitely important. That is for knowledge, we've been hearing it. But what is more important is taking balanced decisions after evaluating the current reality. The incidents have again gone up, deaths have again gone up, and the current evidence that we have about the vaccines, that is even more important to put our ideas into practice. Thank you very much. And I hope in this 15 minutes, I could actually tell you that are we really doing enough? We are trying our best, but there's lots and lots to do more. Thank you very much for your patient hearing.
Thank you, Dr. Krishnendu. I will hand over the proceedings again back to Dr. Dipanita. Please carry forward with the program. Are we allowed any questions, or are there time constraints?
Due to time constraints, sir, if we have any questions, there are questions in the chat box and the question and answer box as well. I would request the faculties to address those questions through their chat box or the question.
Thank you, Professor Krishnendu. Thank you very much.
Thank you.
Thank you very much.
Krishnenduda, thank you, Bhagya Madam, thank you, Dr. Rahul Rai Chaudhary and Dr. Biman Chakraborty for such a lively and wonderful session. So now the word cancer, it comes with a lot of fear, anxiety, and negative thoughts. But once the suffering of cancer is sometimes not the pain that one makes one suffer, it's the thought, negative thought which makes the one to suffer. With advancements in medical science, we now think about the fertility preservation in gynec cancers patients as well. So to chair our next session of keynote lecture, I would request Dr. Professor Geeta Ganguly Mukherjee to chair this session. The Professor Dr. Geeta Ganguly Mukherjee has a long teaching experience in obstetrics and gynecology at NRS Medical College, Bankura Shammilani Medical College, and ICOG Medical College. She worked as an HRD, Chief of Center of Excellence and Officer in Charge of HRRCC ICMR at ICOG Medical College. She is ex-president of the Bengal Obstetric Gynaecological Society, ex-vice president of FOGSI, ex-president of Indian Society of Perinatology and Reproductive Biology, and many more. Madam, the stage is yours.
Thank you. Very good afternoon now. I must thank BOGS for arranging this so nicely fertility preservation in women with gynecological cancer. You know, many women, in their reproductive age, they are suffering for cancer. And we all know that treatment-induced ovarian insufficiency and infertility is there. But many of them wish to preserve their fertility because they want to have kids. What to do it? It is a problem now. It depends upon the patient. How is the patient? How is the disease? What is the stage of the disease? We all know that embryo, oocyte, and ovarian cryopreservation are considered promising modalities used in gynecological cancer for preservation of the fertility preservation. Fertility preservation nowadays is emerging as a distinct and specialized field of reproductive medicine. And for this, an improved standard of practice is necessary, which may lead to much better patient care, because everybody is not ready for this fertility preservation. Anyway, and we are all eager to hear from Dr. Nandita Palsetkar, who is a specialist ART personalities. There is no need to discuss her academic biodata. She is very known to all of us, very dear to us. And Nandita, I think you can hear. Yes. And I personally know Nandita for many, many years. She was also is a writer in my book, 2 or 3 books. But as it is necessary, I am saying her biodata is director at 9-room IVF Center, professor in obstetrics and gynae at D.Y. Patil Medical College, Mumbai, teacher of super specialty, president, All India, former president of FOGSI, 2019 to 2020, former president of MOGS.
Thank you, Dr. Ganguly. Thank you.
Yeah.
Thank you. Dr.
Nandita, I am very happy to see you, though it is virtual. We always want to have physical, but it's not. The stage is yours. We are all eagerly waiting to hear your lecture on this important and subject nowadays.
Thank you, Dr. Ganguly. Thank you so much. And it's such a pleasure to talk in the presence of such seniors. Dr. Chakravarti, very nice to see you. And a fabulous talk given by Dr. Krishnendu and Dr. Bhagyalakshmi. I think I really enjoyed that. And I would really like to thank my friend, Dr. Bhaskar Pal, for inviting me here today. And Sita and Bhaskar have been friends for a long time. And it's really a pleasure to come to Bengal OBGY Society, because you always are presenting a lot of work. In fact, when I had to prepare this talk, as I was telling Krishnendu, that I was, finding out all the latest stuff, because I know Calcutta is a fantastic society, well-read and up to knowledge with everything. So I really took trouble. 1 minute, let me just put this, yeah. So I said, I have to be totally updated. And this is something very, very close to my heart. And I have been involved, and I am doing a lot of fertility preservation for, now the slides are not moving. I'll have to just stop sharing and come again. There's some technological issue. Have I escaped? 1 minute, sorry. I'll have to start sharing again. Sorry. Yeah, can you see now? Yeah, okay. So this is a subject which I've been doing a lot of work in, and it's very close to my heart. And I feel this is a technology, fertility preservation, which has really evolved into excellence. And today it is empowering all the cancer-ridden patients who are now cancer survivors. And this is something that we must remember. As the cancer survival rates actually increase among the children, among the adolescents, and among the young adults, the need for fertility preservation, awareness, and counseling has really grown in parallel, because we are treating them and we are giving very good survival rates. And you need to think about their quality of life and their future. And as an infertility specialist, they are coming to me that they want to have children because they cannot conceive. So I think, as all of us gynecologists or as women health providers, we need to be aware, because we are the first contact. We are, in fact, the people who diagnose gynecological cancers or any other cancers in these sets of women. And we must be, we must make these people aware about the fertility preservation in cancer patients. So it is a real cooperation between fertility preservation specialists, oncologists, healthcare workers, and the patient. In fact, it is very sad, and there was a recent paper by Anna Kubertal in the recent Fertility Sterility of May 2021, just published, saying that most of the patients that came to their unit for egg freezing came after they had taken one cycle of treatment. So there is no advice for fertility preservation given by the doctors. Their patients themselves found and then came. So I think it has to be a cooperation. Pradeep, sorry, there has to be a cooperation between fertility preservation specialists, oncologists, and other healthcare workers and the patient. 1 minute, can I just switch off this phone? So fertility preservation approaches are made by patients' age. Usually we offer it to patients who are younger than 35, or even 40 can be used as a cutoff. Cancer type of treatments, presence of a male partner, or patient preference for the use of bank donor sperm, or the availability, the time available also, whether the cancer treatment is very, very important to be started immediately, and the likelihood of ovarian metastasis. So when you're counseling, you can talk to them that you can do fertility preservation, the techniques that are available today to you, or of course, oocyte donation is always available to the women, and adoption. And of course, I haven't mentioned surrogacy here, but also surrogacy. I haven't put in surrogacy because of the law in the law is in the parliament and we don't know what is happening. But of course, altruistic surrogacy will always be available in our country. So fertility preservation strategies today, which are legally available and which are not experimental anymore, is the egg cryopreservation or the oocyte cryopreservation and the ovarian tissue cryopreservation. And I'm going to discuss them one by one. So why do we require fertility preservation? There are certain drugs, the chemotherapy which we use, which causes poor ovarian reserve, or it is gonadotoxic. And this is a chart which I keep in my clinic because I cannot remember it. So the high risk, the intermediate risk, low risk, very low risk, or unknown risk. So high risk means what? There's an 80% risk of permanent amenorrhea if you are administered these drugs like HSC-TX with cyclophosphamide or TBI or cyclophosphamide busulfan. So this is the list which you must keep, and you must counsel your patients accordingly when you need to talk to them. Then radiotoxicity also. When there's radiotoxicity, the relevant effects, the dose of radiotherapy which is required at birth, which causes the ovary to absolutely become to go into failure. So this is another chart which I would keep in my clinic. And of course, the risk of ovarian metastasis, because when I'm doing ovarian tissue cryopreservation, we need to find out which are the cancers, like in leukemia, neuroblastoma, Burkitt's lymphoma, and ovarian cancer. Those are at the highest risk of having malignant cells. And that's why you should not transplant, auto-transplant this tissue. And that is why it is very important to remember this. And of course, now there are different technologies available even for those patients. So this slide was very important. In fact, my son today, being Mother's Day, was helping me out with these slides. You know, I was struggling with the color combinations and all. And he was telling me, Mom, why are you putting this slide? But I think it's very important for us to understand that the younger the patient, the less number of eggs are required to give one normal or euploid embryo. So if your patient is younger than 35, you need only 4 eggs to give one normal embryo. So if your patient is young, do the fertility preservation before the patient is older. I think it's very, very, very important for you to remember this. So the the oocyte freezing, if you are doing, then you have to do egg retrieval, egg denudation after 2 hours, cryoprotectant after 15 minutes of denudation, slow freezing, you do storage, and whenever you want to put it back, you do thawing, ICSI, and razor hatching. So the freezing procedure is vitrification, where you can see the blue arrow, where the temperature drops at 25,000 degrees centigrade per minute. And this prevents ice formation within the oocyte and does not damage the spindle. So you can see that the meiotic spindle does not get damaged. And this was a beautiful paper which I was quoting in May 2021, this month's issue of Fertility Sterility, where Anna Kobo has done excellent work in cryopreservation of oocytes. In fact, hers was the paper which led to the world shifting to oocyte cryopreservation using the technology of vitrification. So where she has printed about cryopreservation of oocytes, 2% of all her oocytes which she has cryopreserved is for oncofertility. And out of those 2%, only 7.2% have returned to have a baby. And the key conclusions from her records are that you need 10 to 15 oocytes in less than 35-year-old to have a birth rate of 40 to 70%. And one thing that she says is, it is not a guarantee, it's not confirmed that you will have a child, but it's a 40 to 70% chance that you will have a child with these eggs. remember that oocyte preservation techniques are based on the time available. Now, if you have less than 1 week before starting cancer treatment, it's better to give GnRH agonist to protect the ovary. If you have less than 2 weeks, ovarian stimulation is good and you can do oocyte freezing. If you have 3 weeks, we have double stimulation where we do 2 stimulations in 1 cycle and get as many oocytes as possible. Of course, if those cancers are associated with low ovarian metastasis, you can always take the ovary. After doing oocyte freezing, you can take the ovary and also freeze it. Remember that oocyte tissue cryopreservation can always be done anytime. And if radiotherapy is there, ovarian transposition is also indicated. So we have the ovarian physiology, the menstrual cycle physiology, which we were taught that there's a wave of oocyte follicles which comes in the follicular phase, that has completely been disowned now. There are 2 to 3 waves of follicles which come during 1 month. And that is what this anytime stimulation or random stimulation actually takes advantage of. So you can do stimulation anytime. I can start at the beginning of the follicular phase, or I can start after ovulation in the luteal phase, or mid follicular phase, or even in the mid luteal phase, and I would still be able to get oocytes which I can freeze. And that has really helped in cancer patients when you don't want to wait and you just want to start the stimulation to get the eggs. Ovarian tissue cryopreservation. I had visited Denmark along with my son, Dr. Rohan Palshetkar, to Claus Andersen to learn ovarian tissue cryopreservation. And that was the first time I had gone to Denmark, and this ovary was flown in from another island. And it's a beautiful technology. I don't think this video is working because on Zoom, I don't know how to play the video, but this is how the ovary was taken in a Petri dish, and you actually dissect it to just make, to thin out the cortex. All the stroma is completely denuded, and the cortex is then made into 1 centimeter strips, which is 1 to 2 millimeters thick only, because those are the strips which contain all the follicles, all the primordial follicles. All the follicles are in that cortical tissue strip. And then that tissue is, subjected to slow freezing in those days and frozen and kept. And it was in 2007, nearly 15 years ago, and we have frozen a couple of ovaries by then. That time we were not even getting the media to freeze. I used to ring up Claus Andersen, and he used to send the media for us to freeze. So we had to really plan ovarian tissue freezing. We had to call him up, and the media would take about a week to reach us. So it was, now the media is available commercially. And this paper, which was by Dolmans et al. In May 21, again in Fertility, Sterility, that 285 ovarian tissue transplants have been done. So after they've been frozen, they've been thawed and transplanted. And this is the largest series which has been published of 5 renowned teams. The patients are from France, Denmark, Germany, Switzerland, Spain, and Belgium. Ovarian function recovery has lasted for several years, and the live birth rate is 30%, and this is all natural conception. So it's an amazing technology, and IVF results were like poor responders, much lower than natural conception. But the positive results which were obtained in all patients who were much 5 years younger than those who got negative results. So age is very, very important factors. But what Dolman concluded from his results is that patients, even after several cycles of chemotherapy, even if their ovaries were taken and frozen, those ovaries still acted, still gave them, HRT. And remember one thing, it is not only fertility, it's also HRT. These women are put into menopause because of their cancer. So when you put the ovary back, you're giving them natural HRT, reproductive hormones are given to them. So along with fertility, you're taking care of their reproductive hormones, you're giving them back their bone density, their heart protection, cardiovascular protection, their brain neuro protection. So all these advantages are there with ovarian tissue transplant. This is one of the biggest series presented. In fact, there have been 187 babies born so far, and out of them, only 3 are born of vitrification ovaries, and the others are all born of slow freezing ovaries. And now the trend has started for vitrifying this ovarian tissue. So things are changing, and we will soon see the changes there. Now, is ovarian tissue freezing superior to egg freezing? Definitely yes, because you're getting natural HRT, you're getting a chance at natural conception. So maybe that may be the way in future. Auto transplantation is the biggest fear, as I mentioned before. Leukemia, Burkitt's lymphoma, all these are the cases where you can't put back the ovary back. So there are novel techniques which have been, published by Tefler and Anderson again in the April issue this year, 2021. This is the immature oocytes which are there in the stored tissue are taken out, and you promote the growth using culture techniques which support complete development in vitro maturation of that primordial follicle into M2. It's of course experimental, and the other part is harvesting immature oocytes from the small. That time only, when you remove the ovary, you harvest the immature oocytes, do IVM and store, or to create IVF and put the babies. So these are two technologies which are being offered to the women who have very high chances of metastasis in the ovary. The other technologies that are there is, of course, xenotransplantation, where Sonia Pelliker's group and the EV group has actually taken the ovarian tissue and grafted it onto mice ovaries, and they have infused it with bone marrow stem cells, and follicles have actually grown and they can be removed. I mean, human follicles have been grown. Of course, it's all experimental, it's not been done, but xenotransplantation, and you can grow ovarian, you can grow oocytes. So this is growth of the oocyte in the lab. And of course, growth from the stem cells. But as yet, oocyte competence-like cells have been grown in the lab, but we've not yet grown oocytes. It's all happening in the lab, and cultivation is occurring, but we've not had any, there have to be many studies to see what are the genetic effects, long-term effects, etc. And of course, the final is the artificial ovary. This was especially, I heard Susan Paul's talk 2019 in New York, and she used alloderm, and Octay has also published it. Alloderm is decellularized human extracellular tissue matrix. It's used by a lot of plastic surgeons, and you can use alloderm and create a kind of a matrix, and you can put all these primordial follicles there, grow it outside the body for 2 weeks, and then take this and put it into the ovarian fossa, and it grows into an ovary. And 2 pregnancies Octay has achieved, and Susan Paws has actually grown an ovary out, created an ovary 3D, a 3D print of an ovarian matrix, and created an ovary. So I think there's a lot of things happening, and I would like to have 2 slides about children. Children and adolescents, we can do oocyte retrieval, ovarian tissue freezing, but what about children who are prepubertal? I think oocyte tissue cryopreservation, this is a systemic review published in 2019. 1,000 patients were there, and fertility options available to girls under 20 is OTC, oocyte tissue cryopreservation, and ovarian transposition. And remember, ages were 4 months to 20-year-olds. So you can definitely offer this to patients. And there's something new which was done by, in this February 2021 issue, Hoppin et al. She had done the study on 102 adolescent girls, and parameters such as baseline AMH, agent exposure, type of cancer, age, and she could predict the chance of ovarian failure, and that would help the patient to decide whether to go for fertility preservation or not. I think there are so many things that are coming in our practice to help these patients, and I think we need to be updated what is happening and how we can utilize them in our practice and use them to help our patients. So I think we all need to remember this, that life exists after cancer, and today oocyte cryopreservation and ovarian tissue cryopreservation are no longer experimental. Please, there are a lot of centers doing it. I am doing it. And these, medias are available, these technologies are available, and you can definitely offer it to your patient. So please do not hesitate, contact your nearby centers and see who's offering oncofertility to give these people a chance. Thank you. Thank you very much.
Thank you, Nandita, for your excellent lecture. I am here, I'm sure this will help many. But one thing, for this thing, oncofertility counseling is very, very important, isn't it?
Yeah, absolutely.
The patient, this is very important to the patient, because they must know that they have got a chance to have baby, number one. Number two, what the cancer therapy can do it, but they should not be disheartened. They can have baby, but also they must know the pros and cons of all the procedures. Anyway, thank you very much for your excellent lecture. Dipanita.
Bhaskar, thank you for inviting me. It was a real pleasure.
Yeah.
Thank you very much.
Anyway, we'd be more happier if we could see you physically, but it's not the time. So anyway, we are happy to see you virtually after a long time. Thank you.
Thank you, Nandita madam, and thank you, Geeta madam, for this session. So now we have come to the time when we are going to conduct this 53rd Dr. Shubodh Mitra Oration, Dr. Shubodh Mitra Memorial Oration. So as Dr. Ramprasad De, the Honorary Secretary of Bengal Obstetrics and Gynaecological Society, is unwell today, so he will not be able to join today's oration. I would request Dr. Tulika Jha, the Clinical Secretary of Bengal Obstetrics and Gynaecological Society, to replace for Dr. Ramprasad De. So Dr. Bhaskar Pal is the President of the Bengal Obstetrics and Gynaecological Society. He's a senior consultant of Apollo Clinical Hospital.
I will take over from here. Before I start the oration, I skipped the BOGS president's message at the start of the session, but let me take this opportunity. And to start with, I thank my team for organizing this program, especially Dr. Ramprasad De, Dr. Tulika Jha, and Dr. Sita. And I am grateful to Dr. Bhagyalakshmi Naik, Chairperson of Gynaecological Oncology Committee of FOGSI, and Dr. Sneha Bhuya, Chairperson of Study on Female Breast Diseases of FOGSI, for joining hands with us. And I thank all the speakers, and we had wonderful presentations. And the essence of a clinical meeting or a clinical program is we can learn something new. And I think we've learned a lot from Dr. Bhagyalakshmi's presentation, where we have, where she has highlighted and cleared many doubts. We've learned a lot from Dr. Nandita's presentation, especially for those of us who do not do infertility, as how we can help patients before jumping onto the oncology treatment. Dr. Sneha Bhuya has opened our eyes to what we as gynecologists should do our bit in preventing breast cancer. And Dr. Krishnendu Gupta's was a power-packed presentation in what we can do again from our small bits as far as prevention of cervical cancer can be. And a wonderful presentation by our own clinical secretary, Dr. Tulika Jha. And then we come to the 53rd Dr. Shubodh Mitra Memorial Oration. I request all of you to join me in wishing our honorary secretary a speedy recovery, and hope he is back with us at the next program. I'm delighted to have Dr. R. Shankar Narayan. Dr. Shankar has been not only a stalwart, but he's been a crusader in preventing cervical cancer. There are very few people who...
Ashkada, a bit louder. We can't hear you clearly.
There is some background disturbance, I think. Please mute everyone else.
So which part was not heard, Tulika? Hello?
Tulika,
Which part was
unmute
not heard?
yourself.
Just starting off with Dr. Shankar Narayan, yes.
Okay, I think Dr. Shankar Narayan has been not only a stalwart, but he's been a crusader. He's spent his life in trying to make prevention and prevention of cervical cancer accessible at every scenario, not only at the tertiary hospitals, but even at the primary healthcare level. So it's a pleasure to have him here speaking on cervical cancer elimination. As it is customary, it is for the younger generation and the newer generation to remember our past and our heritage. And I request we have a slightly tweak in the order we do things in an oration because of the absence of the honorary secretary. And I request our joint clinical secretary, Dr. Sita Ramamurthy, to introduce Professor Subodh Mitra to the audience. You're muted. You're muted. Sita, you're muted. Sita, you are muted.
Sita.
Just doing it, yeah. Can you hear me now?
Yes, yes, we can. And we can see your screen as well.
Thank you. Thank you, President. It's indeed my honor and privilege to be presenting to all of you the life and the achievements of the legendary Dr. Subodh Mitra, under whose name the oration will be held today. Dr. Subodh Mitra was born on November 1st, 1896, and he graduated from the Medical College and Hospitals, Bengal, and completed his post-graduation from the University of Berlin. That's his picture. We have some memorable photographs of him and his life. That's his photograph after he finished his post-graduation. He assumed a lot of important positions, out of which he was a professor and director at the Carmichael Medical College, which is now well known as the Arjikar Medical College. And he was also the principal of the Chittaranjan Sheva Sadan College of Obstetrics and Gynecology and Child Health. This is the institute for you. And his lifelong dream, for which he was so passionate about, finally came true when the Chittaranjan Cancer Hospital was inaugurated by Madame Julie Curie in the year 1950. And this was the place where the cancer hospital was started and now doing its bit for the women of our country. His fame was very well known and he was acknowledged rightly at home and abroad. He was invited to several renowned national and international conferences. And to name a few, right then in 1924, he was delegate at the Innsbruck Science Congress, Germany, 1931 at the International Radiological Congress, Paris, 1947 at the Bicentenary Congress of Obstetrics and Gynecology, Dublin, for the British Congress of Obstetrics and Gynecology, London in 1949, International Congress of Obstetrics and Gynecology, New York in 1950, Germany Congress of Obstetrics and Gynecology, Munich in 1952, and the International Congress of Obstetrics and Gynecology, Geneva in 1954. That's a lot for a man at this stage, at that age, to go abroad and deliver his lectures. This was a picture before he was internationally acknowledged for his well-known Mitra's operation. As known, he was very well known for his research work and mainly for his innovative surgical skills nationally and internationally. And he developed and perfected the extended radical vaginal hysterectomy and the bilateral extraperitoneal lymphadenectomy, which was demonstrated in Vienna in 1952 and still being practiced. So his path-breaking work was rightly and officially recognized by the British, American, and the German Gynaecological Societies and was recognized internationally as the Mitra's operation for CA cervix. This is when he had demonstrated the Mitra's operation at Vienna, and his contributions rightly were not only in gynecological malignancies and various new techniques in cancer surgery, but also in toxemia and anemia in pregnancy. His publications, needless to say, were much more than in various English and German journals, and he was awarded the Fellowship of the National Institute. And as an academic administrator, he had a lot to contribute. He was the Dean of the Faculty of Medicine, Calcutta University, member of the Syndicate, Calcutta University, member of the Academic Council of Calcutta University, and also the Vice Chancellor of the Calcutta University, where you see his picture here. And some of his great, as I said, memorable pictures, sharing the platform with Dr. B.C. Roy and our late President, Dr. Jawaharlal Nehru, during his marriage ceremony with his family, as he changed with time, and in a festive mood at the Chittaranjan Seva Sadan. Another picture with his family, the evergreen couple in Japanese style, enjoying the festivals in Hong Kong, well, not in an advocate's chamber, but as an orator abroad. We have such memorable pictures of his work. He was also involved in social work and pioneer in social work at a Lions Club event. This was late, long back. And finally, he preached his last in Vienna in 1961 during the Second International Congress of Obstetrics and Gynecology. So here we are, and this is his memorial. And here we are to have this 53rd Dr. Subodh Mitra Memorial Oration to be presented by Dr. R. Shankar Narayan. Thank you. Thank you. And over to you, Dr. Tulika.
Thank you, Sita. Thank you for introducing late Professor Subodh Mitra. And we are delighted to have Dr. Shankar Narayan today to deliver the Dr. Subodh Mitra Oration. And I would request our Clinical Secretary, Dr. Tulika Jha, to introduce Dr. Shankar Narayan to the audience.
Thank you, Bhaskarda. I'll just share my screen in a moment. Once more. Is it okay? Can you see?
Yeah.
So we all have gathered here virtually, although for the 53rd Dr. Subodh Mitra Memorial Oration. And it's my proud privilege to introduce the orator for today, Dr. Rangaswamy, Dr. Shankar Narayanan, to the audience. As Bhaskarda said, I think Dr. Shankar Narayanan he's a very well-known figure everywhere in India and abroad, but I think crusader is the right word to describe what he has done in the field of carcinoma cervix. Dr. Rangaswamy Shankar Narayanan has completed his MBBS and MS in radiotherapy and clinical oncology degrees from the University of Kerala, India, followed by postdoctoral training from the universities of San Francisco in 1984, Pittsburgh in 1987, and Cambridge in 1988 and 89. He worked at the Regional Cancer Center, Trivandrum, from 1982 to 93. In clinical oncology, cancer registration, and cancer control. And he then joined the International Agency Research on Cancer of the WHO, Lyon, France in 1993. In WHO IARC, he was the special advisor on cancer control, head of the cancer early detection and prevention sections, head of the screening group until his formal retirement happened in December 2017. He advises several Latin American, Middle Eastern, Central American, and East Asian, African countries on cancer prevention and detection, control and development of efficient, accessible, and affordable cancer health services. He has widely traveled in more than 110 countries and provided technical support to national cancer programs and resource development in more than 75 countries in the African, Asian, and Latin American region. He has won several awards. In recognition of his services to global cancer control, he has been awarded the prestigious Princess Lala Salma International Prize, Morocco, the Paul P. Carbone Award for International Oncology from the US, Ruby Hall Award for Excellence in Clinical Oncology in India, Singapore Colposcopy Society Award, Singapore, Ernst Werdheim Prize by Austria. I think this must be really special. Indo-American Cancer Association and Association of American Physicians of Indian Origin Award for Excellence in Global Oncology. The CV was short and no nonsense, like the man himself, but this is over to you, Dr. Rangaswamy.
Thank you, Tulika. Before Dr. Shankar starts, I want to say a few things. I think it is relevant today is that the Chittaranjan Cancer Hospital that Dr. Subodh Mitra founded we have two panelists here with direct link. One is Dr. Ranajit Mandal, who is the current head of gynae oncology there. And one is Dr. Dipanita Banerjee, who's recently moved away from being a specialist there to AIMS. And we also have among our panelists, Dr. Kalidas Bokshi is one of the few people who still who are alive, who have mastered the art of Mitra's operation. But two more things I want to tell about Shankar, that number one, he is the pioneer about the VIA in prevention of cervical cancer. And second, he is the best example as how inventors think and change your adversities into opportunities. We talk of 2-dose cervical vaccine today. We are going to talk about single-dose cervical vaccine today. And that is where he saw an opportunity when the government of India stopped entire research on the cervical cancer vaccination. And he could go back to the data and see that how we could benefit by those, what is the response in those who got single doses and 2 doses. And I guess that is how pioneers differ from mere mortals. Over to you, Dr. Shankar, for speaking on recent trends in cervical cancer incidence in India, implications for elimination. I think Onference would share the slides, isn't it? Tulika?
Yes, yeah.
Sorry, Pharmed.
Yeah. Thank you very much, Dr. Tulika Jha and Dr. Bhaskar Paul, for your kind words. It's really touching. And, hundreds of well-wishers across the world is the most important thing for a massive work to be done. And I am fortunate to have well-wishers everywhere in the globe. And at the outset, I would like to thank Dr. Bhaskar Paul, Dr. Day, and Dr. Tulika Jha and organizers for the honor and the privilege to present the 53rd Dr. Subodh Mitra Memorial Oration. And I feel humble in front of a great personality. My salutation to Dr. Subodh Mitra. In fact, Dr. Sita clearly explained the whole achievement, so I do not want to repeat all those things. But on the other hand, he is somebody who has done a yeoman work as a skilled surgeon, even as a radiation oncologist, an excellent scholar, and a dedicated social worker. And he has been one of the chief architects of cancer research and cancer management in this country. And he has several firsts on his behalf. And he has published in reputed journals. Actually, his landmark publication on the results of the Mitra's operation appeared in American Journal of Obstetrics and Gynecology and British Journal of Obstetrics and Gynecology. And they are really landmark publications reflecting the current, the erstwhile style of doing research and carefully collecting statistics and presenting. And in fact, this is a real honor, and I would like to thank again the organizers for this prestigious honor afforded to me. Dr. Gupta made my job much more easier in a very power-packed presentation on vaccination and elimination of cervical cancer. First of all, what does elimination means? Elimination means incidence of a specified disease is so low in a defined geographical area as a result of direct interventions so that it ceases to be a major public health problem. But continued intervention measures are required to keep the disease low. Typical examples are neonatal tetanus, polio, diphtheria. But on the other hand, people quite often confuse between elimination and eradication. Eradication is complete elimination of disease, but you don't need the intervention measures to continue. The typical example is smallpox. On the other hand, we frequently talk about control, and especially cancer control. What we mean is we want to reduce the suffering and incidence of disease to a certain level by specified interventions. Of the three, elimination and eradication are noble goals. And few years back, we would have never thought there would be a call for elimination of a disease like cancer. And that happened because of very important discoveries which happened in the last decade of the 20th century, particularly the isolation of human papillomaviruses and the worldwide cross-sectional and cohort studies run by Dr. Nubia Munoz in the International Agency for Research on Cancer. This is just to show the prevalence of cervical HPV in sexually active women between 15 and 59 years. This is a very important piece which led to the final conclusion in addition to the basic research work done by Dr. Geraldo and Surasan, as well as other follow-up studies and observational studies done across the world. What you see here is the prevalence of the high-risk HPV infection, HPV 16 and 18, as well as the other high-risk HPV types like 31, 33, 35, 39, 45, etc. So you see there is a direct correlation between the frequency of this infection and the incidence rate of cancer. Guinea in West Africa has one of the highest prevalences, like almost 30% of the women are infected with high-risk HPV types. And you have an incidence rate, very high incidence rate, around 90 per 100,000. And Dr. Krishnendu mentioned about Swaziland, that is the highest incidence rate, where almost 50% of the population have prevalence of high-risk HPV infection. But what is interesting is at the bottom you see Vietnam, Hanoi in Vietnam, where the frequency of high-risk HPV infection is less than 1.5%. And that is one of the lowest incidence rates, around 3 per 100,000. But in the same country, you go to Saigon, which is now known as Ho Chi Minh Ville, the prevalence of HPV, high-risk HPV infection is about 11%, and it has an incidence rate around 30 per 100,000. So it's very interesting, within the same country, within the same state, there is considerable variation in the geographical distribution of HPV infection, which is related to various socio-economic factors which are interwoven in our lives. Next slide, please. Next, please. This is also Dr. Gupta very much concentrated on. The WHO called for implementing the interventions by 2030 by all countries. This is an important public health action where all member states of the World Health Organizations are signatories, including India. And what it calls for is, by 2030, 90% of the girls below the age of 15 years are fully vaccinated. And 70% of the women with at ages 35 and 45 are tested with a high precision test. At the moment, I would say that if it is affordable, the high precision test we aim is HPV testing, because it clearly indicates the women who are at high risk for cervical cancer. But if the test is negative because of its high negative predictive value, it indicates the people who are at the lowest risk of cervical cancer. And then 90% of the women identified by cervical disease. What we mean by cervical disease, both cervical intraepithelial neoplasia and cervical cancer receive treatment and follow-up care. Cervical cancer elimination is very much interlinked with the Sustainable Development Goals by 2030. For the target 3.4, that's a 30% reduction in mortality from cervical cancer. Next slide, please. Next. And the 2030 targets and the elimination threshold are subject to revision. At the moment, WHO has fixed a threshold of 4 cases or less than 4 cases per 100,000 population as the threshold to indicate elimination. But ideally, one would look forward to a situation where there is 0 incidence. And this is not unlikely. This is going to happen in some of the countries. And some of the countries are also very close to the verge of elimination in few years' time, like Australia and Finland, where the inputs are substantially high. But the problem is a major chunk of the world where cervical cancer is a very high incidence and prevalence. The input measures are far from satisfactory. And we are clearly now seeing in different countries, including India, what a systematic lack of investment in healthcare infrastructure can do in a pandemic or in a medical emergency like COVID-19 SARS pandemic. So there is substantial groundwork to be done if these elimination targets have to be realized. And it is also important to realize how much cost saving these are. These are very much cost saving and suffering saving. And most of these early precancers can be treated on a single day treatments, which will cost substantially lower than what it costs in treating an advanced or a locally advanced, even early cervical cancer. Even in early cervical cancer, when you decide to treat with radiotherapy in poor surgical risk women, you need a complement of external beam radiotherapy, as well as intracavitary therapy by high dose rate intracavitary machines, which will be substantial investments, which is needed. And then as the disease advances, you add concurrent chemoradiation, and this is also going to cost a lot of resources, time and energy, as well as toxicity. Next slide, please. Yeah. Now, if you look at the global situation, the most latest estimates coming from IIRC for the year 2020 indicates about 600,000 new cancer cases and about 342,000 cervical cancer deaths. And now China has overtaken India as the largest contributor of the global burden of cervical cancer. And there is a very important lesson for us, because in this country, there are many people, including experts, saying that, oh, the falling rates will take care of itself. There is no need for any vaccination. But the falling rates are no guarantee for a future increase, no future increase. And if you take China, China had very low incidence rates in 1970s, 60s. It is like 4 per 100,000. It was exactly similar to India. And then it gradually came down to around 4 per 100,000. There is excellent databases from Shanghai, Shidong, and all those places. But now it is climbing up in the same way it dropped because of the opening of the China, the new lifestyles and things like that. Nobody can guarantee such things won't happen in this country. And it is no secret that almost, I would say, around 85% of the cases and deaths occur in low and middle income countries. And the knowledge that HPV, persistent infection with HPV, causes cervical cancer, and the lack of persistent infection is a guarantee for no disease and low risk in future. And globally, HPV 16 and 18 now account for about 75% of cancer cases. But there are countries like India and some of the African countries where it even accounts for about 80 to 85% of cervical cancer cases. Next slide, please. So now looking at the overall cancer scenario in India, fortunately, due to the long vision, the forevision of Dr. Usha Luthra and colleagues of the Indian Council of Medical Research and Dr. Jusawala in Bombay, and some of the luminaries like Dr. Krishnan Nair, Dr. Krishnamurthy, and Dr. Krishna Bhargava, and people like that, the National Cancer Registry Program was organized in the early 1980s. And now there are almost like 28 population-based cancer registries reporting cancer incidence in India. Very reliable data, I would say, given the circumstances they are working, and giving us a very valid estimates of cancer incidence. And from where we can project better for the country. So if you see, we have an incidence rate, the overall all cancer incidence rate ranging from 40 per 100,000 in Usmanabad, which is a rural area, to around 270 per 100,000 in Aizawl, in Mizoram. Generally, we notice that in the Northeast, the incidence of cancer is high. The incidence of cervical cancer is also high. And in southern India, the incidence of cancer is high in Kerala because of very specific cancers like breast cancer, colorectal cancer, and head and neck cancer. But on the other hand, cervical cancer is very low. And in fact, the data coming from the National Cancer Registry program has helped us to project total cancer cases for the country around 1.4 million cases, and with a slight excess in women as compared to men because of cancers like breast cancer and cervix uteri. And as one of our esteemed previous speakers mentioned, breast cancer has taken over cervix cancer as the most common cancer in the world, in India, and everywhere now. So this is a problem we need to tackle at the moment. Next slide, please, in addition to cervix cancer. So if you take cervical cancer, there is almost like a 6-fold variation in incidence across India. It varies between 5 per 100,000 in Dibrugarh district to around 28 per 100,000 in Pasimbare district in Arunachal Pradesh. Generally, most of the northeastern states report incidence rates above 25 per 100,000. But there are certain populations like Thiruvananthapuram, Kollam, Manipur, and Dibrugarh, which report less than 7 per 100,000. In fact, there's a tipo there, it's not 10,000, 100,000. And in fact, the latest reports from Pailon indicates an incidence rate around 5 per 100,000. It is close to elimination. So what we learn from here, we will discuss. So our estimates are 97,000 new cases and about 68,000 deaths in 2020, and with more than 60% presenting in locally advanced disease, and we contribute a sixth of the global burden of disease. Next slide, please. Next, please. Yeah. So this is from the National Registry data for the 4 regions of India, showing the results. South India and Central and North India showing the variation. So if you take South India, there is almost like a 3-fold difference in cervical cancer incidence, whereas in Central and North India, it is almost similar. Next slide, please. So if you summarize the trends, there is increasing incidence of cervical cancer in Sikkim and Mizoram states, with an annual percentage change of 2.1% during 2012 and 2016, for which the data analysis, data completion has been ensured. So that means in these 2 states, it is increasing 2.1% per annum as compared to the baseline rate in the previous year. But there is a decreasing trend in all other registry areas, with an annual percentage change ranging between -1.5% in Dibrugarh to around -4.3% in Trivandrum. That means in year after year, the cervical cancer incidence is declining by, for example, in Trivandrum by 4.3%. So this type of decline is also seen in places like Delhi, Koilon, Nagpur, and in Trivandrum, and all these places. Next slide, please. Since we have a long database from populations in Chennai, Mumbai, Bangalore, and Delhi, sprawling over almost 40 years now, we can look into the long-term trends. You look at the period between 1982 to 1986. In Chennai, it was like 44.5%, 5 per 100,000, and relatively high in Bangalore and Delhi, and in Bombay, it is around 18 per 100,000. And in fact, if you see the decline in Chennai, there is almost like a 70% decline in rates. And in Bombay, it has almost a 60% decline in rates. These are natural. There are several reasons for this: socioeconomic development, empowerment of women, women's education, women's earning capacity has increased. I call this as a social vaccination. This is necessarily a good thing to implement specific interventions. This should not be taken as a ploy to refuse specific interventions to populations so that the disease incidence fall remains very, 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 very slow. So at the moment, what is happening is people are thinking, oh, rates are falling. There is no need to do anything. You know, the rates will go on falling because you provide them better water supply. They are all very important. Social vaccination is very important. Socioeconomic development is very important. But on the other hand, we have specific interventions which will further reduce incidence of cancer. And that message is lost when we talk about the decline in rates. And the population is increasing. And then, mind you, these are on specific populations concentrated on areas where there is a better health services compared to our rural areas. And in fact, if you see the states, there is considerable variation. I will show you some very interesting data from Tamil Nadu, which is a population-based registry covering the entire state, covering 8 crores of people, and how different the cervical cancer incidence rate is across the state. Next slide. Slide, please. And then similarly, if you see some of the population-based rural registries like Barshi and Dindigal, there is a slow decline. It is declining, but the decline is very small. And these are populations which have been extensively screened in research programs conducted by the Nargis Dutt Memorial Cancer Hospital, Tata Memorial Center, and the Christian Fellowship Community Hospital in close association with IR. A substantial proportion of the population has been screened. And even then, the rate of decline in the general population is low. This is because of the non-participants as well as on the wider district. But if the screening activities were not there, we can assume that there must be substantial increase in cases. Next slide, please. So this is the age-specific incidence rate in Barshi for the 2 time periods. And what you see here is, in spite of all the interventions which have been put in place, there has been some decline. But if you examine the age-specific rates, for example, if you take the age of 45 to 49, it is almost like 150 per 100,000. So there is no difference in the 35 to 64-year age group. We call this as the truncated age. This is the most productive part of life in a person's life. So if you take the truncated rates, there is not much difference in truncated rates. This is worrying because we have declines, but on the other hand, the truncated rates are remaining somewhat stable. Next slide, please. Next. Yeah. So now this is an interesting data from Kerala. Kerala has traditionally lower rates. And when the registries were started in the late 80s and early 90s, they had an incidence around 11 or 12 per 100,000. And currently, the age standardized investigation in incidence rates by 2016 are 6.8. And in fact, we have been emphasizing in Kerala, particularly with HPV testing, so not crowd screening program later, because the high negative reach the elimination target of WHO. Next slide, please. Next. You can go to the next one. Yeah. Next slide, yeah. Yeah. So this is an important concept that people need to understand. Our truncated rates, in spite of the cancers declining, our truncated rates are substantial. It varies between 14 to 78.5 per 100,000. And the lowest truncated rates are seen in those areas where we have the lower overall cancer incidence rate. And the highest truncated rates, that is the rate between 35 and 64, are seen in populations with high overall cancer burden. So this means this is a very specific target age group where a substantial amount of attention has to be paid by means of screening as well as diagnosis and treatment if you want to reach our elimination goals. Next slide, please. Next. Now, Tamil Nadu is the first state in the country to implement a population-based cancer registration across the entire state. And it has around 2,078 data sources from which data are collected, collated, duplicates are removed. It's a massive operation done by Professor Swaminathan and colleagues at the Cancer Institute in Chennai, supported by the government of Tamil Nadu, as well as partially by the IRC and partially by the intramural grants from the Cancer Institute itself. It covers 36 districts. Next slide, please. And almost 8 crores of people are covered by this population-based registration. And the first report was published very recently. Next slide, please. So if you see here, this is the cervical cancer incidence rate across the different districts in Tamil Nadu. And in fact, it varies between almost a 6-fold difference within the same state. The poor districts having a high rate of cervical cancer, all the things above 20 are some of the poor, socioeconomically less developed as compared to other districts, clearly indicating the fact that cervix cancer is a cancer of the poor people, and we need to have an affirmative action to specifically target this cancer, if you want to reduce suffering for these poor people. So this must be true in each state. If you take each state, if you go on a statewide level, there will be substantial variation in cervical cancer incidence rate, with some of the districts showing very high rates. And in fact, the rate in Perambalur district, it resembles the rate in sub-Saharan Africa. Next slide, please. Next. So, in the year 2016, they had about 7,545 new cervical cancer cases in Tamil Nadu. But look at 2020, they have a head count of 65,000 new cases. So it is lesser than 2016. Good news, because the rates are falling in spite of population aging and the truncated population expanding. There is a decline in the overall cases. And this is also a good thing, because these are the situations where our interventions will work very nicely, because we are not dealing with a massive burden of disease. The disease burden is declining because of various factors in the community, and our specific interventions will substantially reduce the risk, leading to elimination. Next slide, please. Yeah. So this is just to show the truncated rates and other age-specific rates. If you see between 35 and 54, it is around 24 per 100,000, and 55 to 64, it is about 53 per 100,000. This substantiates very well the WHO philosophy of targeting screening for the women ages 35 and 45 at 10 intervals with a high precision test. Because given the limited resources we have and very limited healthcare infrastructure which has been built so far, I'm very glad one of the byproducts, I wish, I'm not glad, I wish one of the byproducts of the lessons that we are learning from tackling the COVID pandemic should caution and should lead to, should stimulate massive investments in healthcare infrastructure and massive upward rising of the proportion of GDP spent in healthcare. For example, Thailand spends about 6% of the GDP in healthcare, whereas our contribution over several years has been a static 1.2 to 1.4% of the GDP. This is not simply acceptable. So it also shows, if you minutely look into the different data points, it clearly shows the amount of investments that we need to make in our healthcare infrastructure. Because caring for the suffering is also very important. Prevention is important, but at the moment, what you visibly see is the caring for the suffering of the people with cancer, and it requires substantial investments to be made. And there are several regions in this country who have very, very poorly developed healthcare infrastructure. It is pathetic to see the level of development of healthcare infrastructure as compared to our neighboring countries like Bangladesh, Sri Lanka, Maldives, and Thailand. Next slide, please. This is to show the age-specific incidence in Chennai over a period of 30 years. The topmost curve is the age-specific incidence in between 83 and 87. This is 93 to 97. This is 2015. What it clearly shows is there is substantial decline in truncated rates over time in the population of Chennai, which could be due to the social vaccination I was mentioning. But with introduction of specific interventions, you also see the incidence is beginning only around 35 or something in Chennai, and specific interventions can substantially reduce the incidence, the truncated incidence from these levels, and the curve can be flattened. Next slide, please. So, I mean, you can skip this slide. Can you go to the next one? Yeah. Next. So, the impact of falling incidence rates on cervical cancer elimination in India. Falling incidence rates facilitates disease control, elimination if effective interventions are available and earnestly implemented. This is very important. You know, we have a screening policy in the country, and there was substantial noise made about implementation of the screening policies across our healthcare services. But actually, at the ground zero level, nothing has happened in many districts. I think the only state which has made some investments in cervical cancer screening is the state of Tamil Nadu, initially through a massive World Bank loan, health infrastructure loan, which is provided by a World Bank, targeting on breast cancer, cervix cancer, oral cancer, hypertension, diabetes, and hyperlipidemia. Specifically investing in different healthcare infrastructure within the primary health center to tackle these NCDs and appointing special NCD nurses and medical officers. Even though the impact cannot be measured now because the inputs are going on, the inputs are quite reasonable for a program, a screening program, because a screening program takes almost like 20 years to reach a certain level of perfection. But other than this, there is nothing much happening in this country Because unless we invest, things won't happen. Unless we invest in human resources, providers, and an effective referral pathway, and an easy access and affordable access to health services is very important. Even with Ayushman Bharat, the government is a payer rather than the provider. First emphasis should be on improving the public health system, and there the government has to be the provider rather than the payer. Next slide. Next, please. So this is a modeling study which was done by some of our colleagues in IARC. And what they are showing is, if you do not vaccinate the girls born between 2006 and 2014 in the world, there will be 11.8 million cases among these birth cohorts by 2019. Just imagine. I was telling about Airbus disaster and things like that. Look at the sheer numbers which will happen in the world. These are very carefully done model studies. And 4/5 of this burden will be in 25 countries in Africa, which will collectively contribute 5.8 million cases. And in Asia, 4.8 million cases. And if not vaccinated, almost half of the cases, that is about 5.9 million cases, would affect birth cohorts in India. India is the #1. This is going to happen in a big way in India as compared to China. So India, Nigeria, China, Tanzania, Indonesia, Uganda, Democratic Republic of Congo, Ethiopia, and Kenya. So these type of modeling studies are very useful, in cautioning us what can go wrong if you don't make substantial investments. Next slide, please. Next, please. Yeah, this is my last slide. It will be interesting to see what happens in our neighboring countries vis-a-vis HPV vaccination implementation is concerned. Sri Lanka has implemented. Thailand is now nationally covering with HPV vaccination. Even Myanmar has started a national program. Maldives has a national program. Bhutan was the first country in the Asian region to start HPV vaccination in 2009. And they are now almost 12 years down the line, and they are starting HPV screening. Nepal has completed the pilot program for Gavi eligible vaccine doses. They are waiting the Gavi's benevolence because there is a huge vaccine shortage at the moment. And Bangladesh has completed the Gavi demonstration programs and waiting for the Gavi vaccinations to come. And even Indonesia has implemented in 3 districts, 3 provinces in Indonesia. And they are going to cover the entire country within the next 3-4 years, according to their plan. We don't know whether it happens because Indonesia is a very challenging country to provide healthcare because it's an archipelago with more than 7,000 islands habited by people. But if you take India, which is the major country in the Southeast Asian region, only Sikkim has implemented a systematic public health vaccination program covering the entire state. It's a small state, of course, but on the other hand, the foresight of the policymakers to implement HPV vaccination is a remarkable thing. In Punjab, 2 districts have implemented. Delhi started implementing, but not in an organized fashion. There is a large amount of things need to be done in this region, particularly in India, if you want to reduce the morbidity and mortality from cervical cancer. And Dr. Krishnendu Gupta referred to a single dose of HPV vaccination. In fact, there is very strong observational data emerging from our study in India, as well as in Costa Rica and routine population-based screening programs across the world that a single dose of HPV vaccination provides substantial protection. And in fact, the WHO will be soon examining this single dose vaccination data to come out with a proposal. And there are randomized studies already ongoing in Africa and Costa Rica and places like that, comparing a single dose with 2 doses. And the Indian study, currently coordinated by Dr. Partha Basu and Dr. Neerja Bhatla in New Delhi, with about 9 participating centers, is a very good example of what can be achieved if researchers cooperate and under challenging conditions continue their research. And in fact, the data emerging from this study is one of the very valuable contributions to ultimately a single dose policy for at least girls between 9 to 14 years. But in our study, which involved people between 10 to 18 years old, in all the age groups, a single dose performs as good as 2 doses or 3 doses in reducing cervical HPV infection, as well as, we have started screening them, even cervical precancerous lesions, but some more follow-up will be needed to accumulate substantial cases. And the second point, the vaccine deficiency is a major problem. And the vaccine deficiency can be addressed only when the developing country manufacturers come into the fore. China has already licensed a vaccine which is available within China, Sequelin, and which is now undergoing a WHO pre-qualification process. In India, the Serum Institute HPV vaccine has completed the phase 3 trials, and the data will be analyzed. And the Indian drug controller made a dramatic decision to license the vaccine if it shows equivalent in immunological response as compared to the comparator vaccine, which is the quadrivalent vaccine by Merck, Gardasil. So this will substantially make the vaccine available for public health purposes and the open market for prescription, rather than waiting for several years to have a CAN2, CAN3 endpoint. And at the last, I would like to thank again the organizers for giving me the honor and the privilege to present the memorial oration in the name of a great gynecologist, a great social worker, and a great radiotherapist by self-learning, because I'm qualified in radiotherapy. And it reflects the tendency at those times. Many surgeons used to be interested in radiotherapy, and Dr. Mitra was not an exception. Thank you very much for your kind attention.
Thank you, Dr. Shankar, for the wonderful oration. And I think the first on the point that you finished, I think I was training my early days in Eden Hospital when Dr. Biman Chakravarti was still a professor and head of unit obstetrics and gynecology. And at that point of time, we've never seen oncologists. I think we've seen our teachers do the surgery and then plan the further treatment. It is with progress, we have medical oncologists, we have radiation oncologists. But I think in that era, the gynecologist only decided that what would be the chemotherapy or whether who needs to go for radiotherapy. The second thing is that I think the entire narrative has changed in cervical cancer. I think 20 years back, we used to lament that how we do not have a program for screening for cervical cancer. But now with the arrival of the vaccine, we have renewed hope. And I think vaccination drives are a success story in India. The way we've initiated pulse polio or initiated other immunization programs, it tells us if there is some political will, then we will win the battle against cervical cancer. Thank you very much. And I would request Dr. Tulika Jha to put up the plaque that Dr. Shankar will send you to your address. It will courier it to you. I also thank 2 people in attendance today in the panelist link, Dr. Neerja Bhatla and Dr. Professor Sushil Giri and Professor Neerja Bhatla, both very, very zealous about cancer, gynecological oncology, and it's a pleasure to have both of you here. Tulika, would you read the plaque, or I will?
You read it, Bhaskar.
Okay, it's too small for my eyes actually.
Oh, I'll read it.
It's okay. It's okay. It reads, on behalf of the members of the Bengal Obstetrics and Gynaecological Society, it is our great pleasure and privilege to honor Dr. R. Shankar Narayanan, MBBS MD, former Special Advisor of Cancer Control, Head of the Cancer Early Detection and Prevention Section, Head of the Screening Group, WHO IAC Lyon, France, for delivering the 53rd Dr. Shubodh Mitra Memorial Oration live on Sunday, May 9, 2021. And it is signed by yours truly and Dr. Ramprasad De, Honorary Secretary, BOGS. Dr. Shankar, please accept the plaque virtually and it will reach you.
Thank you very much, Sam. Thank you, all of the panelists and the fellow speakers and respected teachers. I think Dr. Chakravarti is in the audience. We had a long association with him 20 years back, and a long association with even with Ranajit Mandal, Partha Basu, many of them. You know, Bengal is very special, my heart, because some of our early studies were done in Bengal. Thank you very much, sir, for the kind invitation and your kind words.
And the person who followed Dr. Shankar into IAC after his retirement is Dr. Partha Basu from Kolkata. Can I hand the proceedings over to Dr. Deepanita, please?
Thank you so much. Thank you so much, sir, for delivering a wonderful oration as usual.
Thank you. Thank you.
So we are at the end of our session today. May I request our Honorary Joint Secretary, Dr. Joyita Chakraborty, to give vote of thanks, please.
Good afternoon, everybody. Our heartfelt gratitude to Dr. Shankar Narayanan for delivering the 53rd Dr. Shubodh Mitra Memorial Oration. Very special thanks to our national faculties, Dr. Nandita Palshitkar, Dr. Sneha Bhuyar, and Dr. Vijayalakshmi Nayak. Thanks to our very own excellent speakers, Dr. Krishnendu Gupta and Dr. Tulika Jha. Thanks to our chairpersons, Dr. Kalidas Bokshi, Dr. Ranijit Mondol, Dr. Biman Chakraborty, and Dr. Geeta Ganguly Mukherjee and Dr. Rahul Roy Chaudhary. And of course to our president. Thank you, Deepanita, for wonderfully coordinating the whole program. Thank you, Dr. Jayanta Jana and the entire team of Pharmed for being our academic partner. And lots of appreciation and gratitude for the audience who were with us on this Sunday morning. Have a wonderful evening. Most importantly, stay safe, take care, goodbye.
Thank you.
Thank you very much. Bye, stay safe.
Thank you.
Dr. Jayanta, are we offline?
Yeah, just close the session.